21.5%. 21.5% of the population in Pakistan are in the range of 15 to 24 years. That is very young age group. Similarly, 47% of the Saudi nationals and 41% of the total population of the Kingdom of Saudi Arabia 24 years of age. So I'm just taking the nearby Asian countries before coming to India. India is a prototype of the low and middle countries because population is more than 1.4. It's now 1.45 billion, and India has become the most populous country in the world. People under the age of 25 years constitute about 47% of the country's population, and population under 25 years of age includes 47% male and 46% female. One of the interesting aspects is that the death rate in India has witnessed a significant decline over the last 4 decades, from 15% in 71 to just 6% in 2018. Young people, rich divide. Young people, rich dividend. Access to their mental health care is the best investment. So this is something we try to tell the policymakers. We have many young people, and the young people in India are far outnumbering the older people, and invest in their mental health. It is going to make a rich dividends. And some of the key legislations, key challenges in these countries are legislation and policy, and finances and resources. Of course, we know that very trivial amount is spent for mental health. Organization and planning, there is little organization and little planning. Availability of appropriately adapted evidence-based interventions and training. So these are the key challenges which I can foresee. In taking up legislation, many low and middle income countries lack mental health policies and laws to direct their mental health programs and services. Family and user associations are present in LMICs, but do not have a strong influence in the development of policy and procedures. Serious oversight, considering that the majority of people with mental illness and low and middle countries are supported by the large family unit. So here is one point I would like to specially mention, that especially in the Asian region, the family has a major role in the treatment of mental health problems. In my unit, I have 40 beds, and almost invariably everybody is accompanied by a family member. This is almost impossible. I'm sure when I was a WPA General Secretary General, I was working in the University Hospital, Geneva, for 6 years, and I have seen that this hardly ever takes place which most of you know very well. So this is one aspect which I would like to highlight. The family is a big source of strength in the low and middle income countries, and we must make use of them. WHO describes the necessary step to follow, but does not detail how this can be contextually relevant to a particular culture. So this is, if suppose we blindly follow a WHO manual, we will definitely reach a blind alley because we do not know how it applies to a particular culture. So these are, WHO has done a good thing is for people like many of us to develop culturally relevant, contextually relevant systems, how we can implement them. So finance and resources, many low-income countries, including 15 of the 19 African countries, allocate less than 1% of their health budgets to addressing mental illness. So this is a very serious situation. Primary source of mental health financing in descending order are out-of-pocket expenditure by the patient or family. This is a huge burden on the families. In fact, they form the number one resource for mental health expenditure. Taxes, social insurance, and private insurance. India is a fast-growing economy, now the 5th largest global economy, but it spends less than 2%, spends 2% of the country's GDP on healthcare in 2022. This to reach 2.5% GDP by financial year 2025, and 1% of the health budget is very trivial. So it's health budget. We are trying our level best to convince the the administrators and the policymakers. And our efforts have, of course, I'm sure the efforts are, I won't say it's a failure. It has partially succeeded in increasing the finance allocation to a large extent, but not enough. We have miles to go before we sleep and miles to go before we sleep. And then organization planning, key organization barriers or difficulty in access. How to make accessible. The competing public health priorities. Now, public health priority, for example, when the COVID came, all other priorities were lost. For example, mental health became very low priority, then even vaccination. Low. So there is always a competing public health priority. Low investment in mental health services, a paucity of specialist human resources, and resistance to decentralization. For a country, huge country like India with 1.4 billion population has just 7,000 psychiatrists. Making one psychiatrist who take care of 200,000 population, which is an impossible task. The number of psychologists, social workers, psychiatric nurses are equally less. This is very true, not only about India. If you take other South Asian countries, it is even lesser. So this is something which is we have to find a solution. We are there in the resistance to decentralization. In India, mental health services are integrated into primary health services with support and supervision from mental health teams at the district level. However, not all districts are covered under this program, and many primary health care physicians have not received any up-to-date training in mental health. This demonstrates a lack of organizational planning in this important area. Of course, this is some of these things we have to look into. Availability of appropriately adapted evidence-based interventions and training. Psychotherapeutic interventions are not included in mainstream treatments in many LMIC countries. That is a very sad state of affairs. This can be attributed to two main reasons: lack of resources and inadequate training. Despite the strong evidence for its effectiveness, cognitive behavior therapy and many other psychotherapeutics and social interventions remain underutilized in clinical settings internationally due to the limited availability of comprehensive training programs and qualified CBT mental health professionals. In addition, as currently delivered, CPD has been criticized as being West-centric and not in tune with different cultural beliefs. Of course, we have to look into this. We have to make CBT and a tool which is appropriately culturally relevant, and also how relevant it is to the Eastern philosophies. For example, we speak about in India, but the Guru-Chela relationship. This is very different from the Western context, where the therapist is at equal level, almost at equal level with the client. But in India, the Guru-Chela relationship, the therapist is seen as a guru, is a teacher who knows everything, and the disciple looks upon him to take decisions and to guide him. Very true in psychotherapy as well, which is modeled on this basis. So we cannot just abandon our patient saying that you decide for yourself. So these are some of the contextually different characters we find in many of the low and middle countries. Now, key challenges: psychiatrists continue to advocate for the introduction of mental health care in primary care without acknowledging the complex realities of primary care in low and middle countries. Nevertheless, the addition of mental health programs requires robust primary health systems. Primary care in lower countries at present systematically underfunded and impoverished, is unable to successfully integrate mental health care. Case Jacob has very nicely brought this out. The primary care, integrating mental health in the primary care is a very wonderful idea. It's an excellent idea. But the mental health care is overburdened. They are not able to look after even their own priorities, like vaccination or child and maternal health programs. So introducing mental health becomes a difficulty. So it's not that the idea is good, but we have to work to strengthen the primary care first and then integrate. And also to think of other strategies. I would just like to briefly speak about the National Mental Health Survey in India, because it's a survey which has been hailed as one of the excellent survey, which was done under the leadership of the National Institute of Mental Health and Neuroscience in Bangalore. I would just highlight some of the key findings. One is that mental disorders contribute to a substantial disease burden. So we need this data to tell the politicians. Excluding tobacco use disorders, mental morbidity of individuals above age of 18 years was 11%. The lifetime prevalence in the survey population was about 14%. Prevalence of mental morbidity is high in Indian urban metros. The prevalence of schizophrenia and other psychosis. I have given the percentages in the brackets. The mood disorders and neurotic stress-related disorders, they're quite high at about 7%. Was nearly two to three times more in urban metros. So urban metros have a key role. One of the key areas where mental health strategies need to be worked into. So this is a graphic representation of the rural-urban differentials in prevalence of the mental disorder. You can see that the maroon bar represents the urban metros, which is quite high for the in total, as well as psychotic disorders, MDD, neuroses. So you can see that it's quite then others are common mental disorders, including depression, anxiety disorders, and substance use disorders are huge burden affecting 10% of the population. 1 out of 20 people in India suffer from depression. And there is high prevalence of psychoactive substance use. Substance use disorders, including alcohol use disorders, moderate to severe use of tobacco, and the mild one is excluded, and use of other drugs, illicit and prescription drugs, was present around 22% of the population above 18 years in all the 12 surveyed states. It's a huge 1/4 of the population above 18 years using substances. It's a very serious challenge. So we have to look into this. And then high suicidal risk is an increasing concern in India. Nearly 1% of the population reported high suicidal risk, total population. And the prevalence of high suicidal risk was more in the 40 to 49 age group, about 1.2%, among females, and in those residing in urban metros, which is 1.7%. The overall prevalence of mental morbidity was higher among males, 14%, than among females. So more of the Indian male suffer from mental morbidity, probably because of the heavy burden of the family. Family burden is there, and also because of the substance use disorders, which are much more prevalent in the males than the females. Female alcoholism is much less in India, maybe less than about 2%, but it is much higher in the males. And this is again prevalence of mental morbidity in different age groups. You can see that the 40 to 49% age group and the 50 to 59%. Interestingly, people above 16% also, 60 and above, also contribute 15% have a mental health problem. And the largest survey of mental morbidity in India, 150 million individuals suffer from mental morbidity in India. This information should be used for planning, delivery, and evaluating mental health programs in the country. This data helps to strengthen and implement mental health policies and programs. This builds a strong case for increased mental health care, increased investment in mental health, and to make mental health priority. Of course, the Indian Psychiatric Society, as well as various other organizations, the lead institutions like National Institute of Mental Health and Neurosciences, the PGI in Chandigarh, and others are using this data to advocate for mental health advocacy. We need time, because mental health is, of course, as usual, mental health is not a subject of any relevance or the forefront of our thought process for the policymakers. Now, coming to the end of my presentation, the way forward, suggested approaches. I would suggest that we should develop guidance on standardized reporting of community components for mental health services. Study approaches to increase service, user, and family involvement in developing and implementing community mental health services. As I was saying in the beginning, family involvement becomes very crucial, and their opinions and their values are very, very important. Their suggestions need to be taken. It's true of all countries. Develop tools to study and promote competencies in community mental health care and use these for research and quality improvement. So competencies are available in the community that should be used. For example, competency in the among the non-governmental organization, the family members, even among users. And this is used for quality improvement. Use technology to expand the scope and improve the quality of community and mental health care services. Telemedicine is one of them. Integrate and evaluate tools for service providers and service users to enhance reach and effectiveness of community components. I will mention about these, some of these experiments in India later. Better integrate community platforms into other systems of care. So just let us not put a community platform as a standalone concept. It should be integrated into primary care. It should be integrated into the private mental health services, integrated into the non-governmental organization, to rehabilitation centers. And these are some of the promising initiatives. One of them is which we have published. Effectiveness of a new low-cost psychosocial rehabilitation model to reduce burden of disease among persons with severe mental illness. Intervention follow-up study, which was led by me and my team. And here we can see that we have been able to provide a community-based service, and we had the low-cost psychosocial rehabilitation model was found to be effective. This could serve as a model not only for other similar centers in India, but also for other low and middle income countries. We used art, we used theater, we used music, and we used other rehabilitation models to provide better quality of care for our people. This is another, the NIMHANS, effectiveness of the NIMHANS eco-blended tele-mentoring, a model on integrated mental health and addiction for counselors in rural and diverse districts of Chhattisgarh, India. So from NIMHANS, they have managed this care for a very rural area in India. This is another by distance training for delivery of psychiatric service in primary care. And this is then designing and implementing an innovative digitally driven primary care psychiatric programs in India. Some of the interventions which have been published. And then promising schizophrenia and research foundation. And this is one. Maria Sadanam in Para, this is one of the centers under where I am the chief mental health advisor. I mean, this center, for example, is there are 450 people who have recovered from mental health or partially recovered are housed here undergoing rehabilitation. They are trained for various livelihood, and once they are better, they are sent back to the community. This is an NGO run, and this is entirely funded by the contributions from the public with very little government support. So you can see that. Just want to bring to the attention the valuable services given by the non-state actors in various parts of India. And in conclusion, I would say that, quote, of all the models by which patients may be induced to restrain themselves, regular employment is perhaps the most generally efficacious. We had to work with companies, working with various industries. In India, what we have 2% of corporate social responsibility, CSR funding. So the government has mandated that 2% of their profit should be earmarked for corporate social responsibility. Most of these funds do not come to mental health. They go for cancer care. They also go for tertiary or quaternary care in cardiac services, bringing in cardiac catheterization. But bringing mental health is our agenda. And we hope to succeed in the years to come and persuading at least some of them to think of mental health as a priority area. It's a very difficult task because one of you are not in the radar of politicians, because we come in the radar themselves come in to seek our help. And once they seek our help, they always do it in because of the stigma and discrimination. They always do it in private, and hardly anyone would like to publicize their publicize themselves as users, one of the benefits. But slowly, for example, Kerala is a state where we have been able to overcome to a large extent. Kerala is where I work, is the southernmost state in the country where literacy is quite high, it's 96%. And this is one state we have we have about 34 million people here, and we have 1,000 psychiatrists, which is far higher than the national average. So this is one, and psychiatry has gained acceptability. Another thing which has happened here is what we call one revolutionary change here is what is known as a general hospital psychiatry. Psychiatry units have sprung up in all the districts and small towns, maybe 10 beds, maybe 20 beds, but they have gained acceptability. But again, we have a lot of stigma. The Mental Health Care Act, which in India, which has been modeled it has actually a cut and paste model by some of the policymakers, where it makes sometimes difficult. Practice becomes difficult. Recently, I was some of the a unit, a psychiatry unit functioning in a medical college. The professor called me and said, now they are asking us to take registration under the Mental Health Care Act of India. Why are you stigmatizing psychiatry? Why no other branches in medicine need such a certificate? These are some of the important questions in law and medical countries which we had to sit together and find out reasons. And these are some of the references. Thank you very much for your patient hearing. Thank you. I am coming to the end of my presentation. Thank you.
Right.
I can stop sharing, I think. Yes, is it possible? Or
I think you can stop sharing. Yeah,
Thank you so much, Professor Roy Abraham, sir. I have just a single query to confirm. The World Mental Health Survey that was conducted in early part of this century, they found a mental health treatment gap of somewhere around 90% patients were having psychiatric illness, but they are not able to get the mental health care. So treatment gap was around 90%. When it comes to National Mental Health Survey of 2015-16, the mental health treatment gap was found to be somewhere close to 85%. I'm expecting that during this COVID times, the mental health system was completely collapsed. People were not able to have access to mental health care. So the gap must have increased to multifold. But recently, over past 2 years, at least the government has taken an initiative to start providing the online services, particularly starting the telemanaged services, which is being implemented in many parts of the country. And the district mental health program has also been implemented in many of the districts of several states. So now the National Mental Health Survey is again going to be held in 2023 and 2024. It has been initiated the phase 2 of the survey. So what do you expect that the treatment gap will be changing? What is your perspective about this?
I fully agree with you that there's a huge mental health gap, and our aim is to reduce this gap. And I also agree that COVID, we really faced a very tough situation where patients in India and other low and middle countries, they simply went without any treatment because they were not at all considered as a priority person to make costly investments. In India, of course, these are manus and tele-psychiatry schemes. Various state governments in Kerala also, they have implemented what we call suicide prevention helplines. But that they're all good, but I think that is not enough. In psychiatry, at least I believe, at least our experience shows that a person-to-person interaction facilitates empathy. And what we have observed in our through telepsychiatry, our experience has been when acute problems are there, they seek our help. So we talk to the at a distance. We talk to the primary care physicians. We make a diagnosis of acute, maybe schizophrenia or mania, and then the treatment is provided, but they hardly come for follow-up. They once after 3 months, follow-up is almost nearly it comes down heavy, drastically down. Whereas in person-to-person interactions, we have followed up in our hospital. I have seen, I was part of the National Mental Health Program in India. I was in charge of the Idukki district in Kerala when I was a professor in Kottayam Medical College, which was a government college. At that time, the WHO sent one of its advisors. And he looked up at the files and he told me that if you have 30 to 40% of persons coming for review, I would rate our system as excellent. Of course, we are at least about 50% at that time. In our institute, we have found that the follow-up rates are about 70%. But when it comes to telepsychiatry, it comes down less than 20%. And so that is a difference. I talk to the politicians, they don't want to listen to you because they want to say that by telepsychiatry, we are covering the entire population, which is, of course, they are covering, but they are not following. We know that mental health disorders, schizophrenia, bipolar, they all need long-term treatment. They need prophylactic care. We have to advise patients, you have to take lithium and you have to take periodic lithium estimations. We have to take all these things. You should not, when there is a dehydration, you should have to stop medication. All these things all these things become very difficult. But they are excellent initiative. But I'm sure the initiatives in India, I applaud them. We hope to reduce the mental health gap to at least manageable limits, at least 75%, maybe by 2030. Let's hope so. Thank you.
Yeah, can I ask one question? So maybe, what is it what poor countries and what rich countries could learn from your approaches? And the second thing I'm quite interesting on the news, that caste is still a problem in India. So what does it do? So is caste a problem or is it a helper or what can you do? So these are the two quick questions.
Yeah, first is what the rich countries and the lower income, low and middle income countries can learn from each other. So rich countries should also always learn when you prescribe, for example, most of the guidelines, most of the textbooks, they all emanate in the West, Western authors, the guidance come from there. They all discount the involvement of the families in the eastern or the low and middle countries. So we should always keep the interest of the family also, because family in most of the Western developed countries, they are user driven, where the patient decides what is best for them. But in countries like India, person is a member of the family. If my brother is ill, the entire family is concerned about it. They are genuinely concerned. That has been the culture of the society. It's not something which we are asking people, no, brother, you come, you take care. No, they are there already because they are part of their family. They have grown up together. And this resource has to be utilized. And coming to your second question, which is very interesting about caste. This is, this is very surprising. Caste system is very much there. But, scientists are, unfortunately, they are probably, I don't know why it is happening. They don't study this aspect. I don't know, they are politicians. They are probably afraid of politicians. I have hardly come across any of the diseases in a high caste, low caste, or the intermediate caste people. This is one area of research which we should keep in mind. Thank you.
Thanks a lot. Maybe you can ask if there's any other questions. I don't know.
Any other questions, please? Or any other one want to add something to the presentation.
One thing I just add is, since Rainer has mentioned about caste, in India we have two types of people who are very underprivileged. One who are known as the scheduled tribes, and the other is known as the scheduled castes. The scheduled tribes are, you can say, people who are indigenous people. Mostly they are living in the forests, and even now they have very little access to the civilization, except in some of the states like Kerala, where they still live remotely, but people are able to connect with them. So there the treatment has not reached them. Access to care becomes maybe 1%, 2%. And in this other underprivileged caste is scheduled tribes. In many, at least in some places, of course, not Kerala is not one of them. I find that there is difficulty because sometimes it is also forbidden by law. People sometimes practice untouchability, which means it's very inhuman to keep one of your persons as an untouchable. So these are some of the things which may be there, which they are not publicly acknowledged, but we have to keep all those things on our mind. And it's in an egalitarian society, everyone should work together for the welfare of others. This must be true of all parts of the low and middle countries, where a lot of conflicts do occur between various ethnic groups, and we have to work together to find a solution. Thank you.
Yeah, can I ask one more question, sir? Yeah, political instability is an important factor in the LMIC countries. When the government change, the policies also change, the priorities also change. So, do you think that having a stable government will facilitate or stabilize the facility of mental health care rather than having a frequent change of the government? This is one thing. Second thing, like India is one of the important country belonging to this low and middle income countries, and natural calamities are quite common. Sometimes earthquake, sometimes flood, sometimes cyclone are affected. I remember that initiative that you have taken for when there was a Kerala flood, you have taken some initiative to facilitate the mental health care. So during these calamities, actually the mental health care facilities are grossly disrupted. And usually the countries that don't have any specific plan how to address those mental health issues during the calamities, what need to be done, how to make the facilities available to people at need. So what should be done at the policy level, the country level? What do you think about that?
No, these are, Sujit, you have spoken about two very interesting dimensions. One is the political stability. As a general statement, I would say that political stability is good for mental health, because when there is political stability, only we can at least discuss with a person in power who will have at least a guaranteed term of 5 years or 4 years, where he will be able to implement some projects and policies. Of course, there is a flip side also, because if that particular politician is somehow is not very not predisposed to mental health care. For example, there are several countries where people believe that the modern system of medicine which we practice is not the best system, and there can be indigenous systems which may be better, but they are not. There is no evidence based on that. But the politicians sometimes promote these systems for political reasons, because they bring more votes for you. Because the people who practice modern system of medicine, scientific system of medicine, is seen as elitist class. But they are, of course, because they are generally well off, because they are fewer, they are paid more, they enjoy different higher level of. It's very much unlike the Western countries, where there is hardly much difference between a doctor or a nurse or a specialist. But here in low and middle income countries, A super specialist doctor may earn 10 times that of a general practitioner or an ordinary doctor. So that also has a difficult problem where you distance yourself from the common people. So that is one of the reasons why probably politicians have not been very kind to our system of medicine. I've tried. I am also being on a vice president, All India vice president of the Indian Medical Association. Where currently also I'm a member of the Central Working Committee. I always tell my colleagues that we should remain footed, keep our foot down so that we keep our contact with the masses. I'm not blaming anyone that we don't do it deliberately. But when you are a cardiothoracic surgeon, you hardly come across an ordinary people, because people who come for cardiothoracic surgery are only the elite class who can afford to pay for your fee. But at the same time, one way of becoming closer to the poor people is offering free treatment programs, which many of the super specialists have started doing now. So you perform 20 cataract surgeries, give 10% poor for ordinary people. So this will bring the profession closer to the. Otherwise, this other systems, for example, in India, there are many systems of medicine, Unani, Ayurveda, of course, has got a tradition at least, I respect Ayurveda for its long traditions. Ayurveda in pure form, if it is not mixed with other systems, is very good. It has got its own basis. But politicians do not differentiate. They work for homeopathy, they work for Unani, they work for Siddha systems of other systems of medicine, which have very little evidence base. But you can, if there are government, there are many in the West will not know this. There are government posts where they almost get an equal salary and enjoy equal perks like a person with a scientific medicine degree or postgraduate degree. So these are hardly anything which we can help. But one way is not to keep politicians out of your radar. You work with them. Otherwise, if you don't work with them, they will keep you away. So that is my advice to all the low and middle countries. At least I strongly believe that even if you think some of the politicians are corrupt, let us hope that all of them are not, but at least majority are not. So let us work with them. And then the other is disasters. And disasters, Kerala fortunately has not been subject to very severe disasters, but some of them have occurred. Kerala 2018 we had a huge floods, and then we had the tsunami in 2004. These are two, and I have been involved with the both, and especially Kerala floods. We were one of the first to go into the community, because where people and speak to people about the post-traumatic stress disorder, the politicians making them aware, and also we have been able to follow up, and we have published also on our work. So at least once we start working and once we produce some results, people will start listening, and then they will feel that not. Otherwise, mental health is not at all an important thing. When a disaster happens, only the surgical part, medical part, if you have fractures, orthopedic surgeon, the surgeon, the others come. But recently in Kerala, I was very saddened when there was an explosion in a religious place where 3-4 people died suddenly. And then, of course, there was all immediately. It's not a terrorist act, but it was an act by one of the disgruntled previous member of the group. So the brightest thing, or a very unexpected thing that has happened was the health minister on Thursday said, I am going to send the mental health professionals to take care of all the people, to talk to all the people who have been in that congregation, about 1,000 people aggregate, because they may be suffering from mental health trauma. So that is a very, very new thing. I think that some of our work I have started feeling, it started paying off. And people are thinking that mental health, after all, needs to be attended. Thank you very much.
Thank you, Professor Ray Abraham. Over to Professor Rainer. If any final comments about.
I think we have to say thank you, Roy, and I think we have to move over to the next speaker, who is just coming up. But Roy, thanks very much, and thanks for your support. Thanks for your support of Global Psychiatry Archives. And yeah, I think you should come over to Scotland one day and say hello.
I will do that. I will do that. That's the only place I have not visited in UK.
I think it's very beautiful, to be honest.
I know. I know.
It's very, as everything which is very beautiful and green is sometimes a bit wet, you know. So
Yeah.
right, okay. Can I ask Norman Sartorius? Oh, thanks a lot, Norman Sartorius. Would you be able to show yourself and share your screen? And Roy, you're very welcome to stay.
Good afternoon. Can you hear me?
All right. Okay. Yeah. So, yeah, thanks a lot. As I said before today, first I would say, you know, we spoke a lot, and you're one of the most impressive psychiatrists, and we heard a lot what you're doing and how much you work. And I think you have been working with the WHO. You were president of the World Psychiatric Association. I would say I have many great memories, and I think we had great chats. Thanks for supporting. And as we're not just wanting to make a one-man show, I would and have the word, we decolonize today, and that means Sujita Kar will just chair the meeting. And but you haven't been in here before, so I would say if you can share your slides, and Sujit can take over, and I start when I see your slides, I start the recording. You have to go to share screen.
Yes. Can you see the slides?
I can
Yes,
see.
sir. It's visible.
We can see. Yes.
Okay.
Yeah. Yes.
They're visible.
They are visible. Yes.
All right. Well, thank you very much for inviting me. This is the second occasion in which it would be very interesting at some stage to learn more about the people who are with us in these meetings. I hope that you will give us an opportunity to learn who was listening in, and in what way we can be in touch with them, since they are interested in what we have to say. Now, I've been suggested that I should speak about the community care in the year 2023. And I think that we have to remember that in the middle of the past century, 20th century, there was a number of important statements that have been made to create a strategy, postulates of mental health care, how it should be done. And one of the things which was quite clear is what the mental hospitals, which in the past have served sometimes a good role and very often been neglected, and therefore fallen into a state of disarray where the patients had a very bad time. But that these mental hospitals should be closed. There should be people who have mental illness should be treated in psychiatric wards. The psychiatric wards should be placed into general hospitals. We should have an opportunity to see that people with mental illness are no different from people with other illnesses. They should be treated as for their acute conditions and for their significant acute symptoms in the hospital, and then placed back into the community as soon as possible. The communities, on the other hand, have to be prepared to accept convalescents and to think about ways in which they can help them and offer them an opportunity to be included as the members of the community with all the rights and all the other things that are usually offered to people with who are members of the community. There was a number of efforts to ensure that the communities, in fact, do help people with mental illness, and they should make it possible to people who are in the communities but have to go to see a doctor nevertheless, or if their condition is reactivated in one way, to go and see their doctors. It was, for some instances, it was clearly understood. It was said that people who are have no more family or have not been a member of any community for a long time, they should also be given care. And in a number of countries, they created one form or another what was called social homes. And these social homes were to be accepting people who are not mentally ill, but who have in one way or another been damaged by the mental illness and have a handicap of sorts and needs to have some steady support. And these are to be in these social homes, which have been created in some countries in very large numbers. In a country like Slovakia or Ukraine, for example, there were considerably more beds in the social homes, where they were not only made people with mental illness, but also people who otherwise needed help were located and placed to make it possible for them to continue living. Another set of recommendations of the mid-past century was that mental health should be provided by general practitioners, and that we should teach the general practitioners how to provide care, particularly for the common mental disorders such as anxiety or depression, but also for other disorders. We've done in a number of studies in which we have demonstrated that primary health care practitioners can in fact provide significant help to people who are mentally ill, recognize their illness, provide them with some treatment, provide them with advice. And so this was another main line of argument that was there. No hospitals, active, well-run departments of psychiatry, transitional institutions, and communities which accept people and look after them. The last one of the idea of that general practitioners should be in fact participating in training. It was felt that the education in psychiatry was often during medical school not particularly practical, and therefore it was important to train the general practitioners in the recognition and treatment of at least the common mental disorders such as depression and anxiety. And a number of efforts have been done in this respect, including the very important investment of the World Health Organization, which has been promoting the MHGAP set of programs which are helping people to learn how to deal with mental disorders when they discover them. And it was also felt, and it was promoted, that the other people who are not doctors but who are invested in the health system should also be trained and exposed to a decent training, since they didn't have it very often before they started service. It was proposed and promoted that the in-service training should be taking place in all of these different professions, which can contribute such a very important part of care to the mentally ill. So these are more or less the principles which were with us in the 1960s and 70s. It continued to roll on with these same principles, and even today, when you look a little bit to see what are the strategies that we are proposing, and more or less these same principles are being promoted, and the role of the community in looking after people, most of the time, with the exceptions of the short periods when they are struck by an acute illness, the communities were to carry all this. And then what happened? Well, in many mental hospitals in high-income countries have been closed or reduced in size. There was a number of hospitals. I remember one in particular, which I visited for quite a few days. It was a hospital called the Pilgrim State Hospital. It was a hospital with 13,000 beds and 14,000 staff, a village or town, if you wish, on its own, living about 15 kilometers from the other people in the surroundings. There were a number of similar hospitals of that size in various countries, very large, very often with a complete and enormous economy that goes with it and so forth. Well, in many countries, these hospitals have now disappeared, have been closed or diminished in size. And at the same time as these big hospitals have been closed, private hospitals of a small size have sprung up practically everywhere. Italy is a good example for that. In Italy, there was a very famous law which said that all mental hospitals have to be closed, which they did. And all the government-run mental hospitals have been closed practically from one day to another. And when they looked at the total number of beds which were available, they saw that the reduction in the number of beds was relatively small because while the government hospitals have all been closed, private care and private hospitals have grown in size, in number, and importance. And many of the people have, in fact, found their place in these hospitals if they could afford it. If they couldn't afford it, well, they've ended very often in the street or somewhere else. Now, we have done ourselves in the time that I was in WHO, a very large number of training courses for general practitioners and some other staff. Some of it worked very well. The general practitioners were keen to learn how to deal with some diseases, not with all. They were quite happy to learn about ways of treating depression, for example, but less happy the ways to treat, for example, schizophrenia and some other psychotic disorders. So nevertheless, they learned quite a bit, and that was an important thing. And psychiatric wards have in fact been created in a number of hospitals. Very often they were them in a way showing the attitude that people had towards them, that in that the mental hospital was in the ground floor, but very often in the what you call it, the souterrain, the floor under, or in a place in a corner of the hospital complex. Nevertheless, they were hospital and they were very actively working and seeing many patients, and they were quite obviously very useful. Now, the problem was, of course, that the mental hospitals, which are very large, when they were closed practically overnight, very few countries have in fact provided sufficient something that would keep these people who came out of these hospitals, very often handicapped by a long stay in a rather terrible situation. They forgot how to live in a community or in life outside. And so many of them, in fact, ended up by being found as vagrant or traveling from one market to another and eating garbage that was left over after the markets were closed. Some others were, in fact, almost without knowing, having unlearned how to live in a community or in a society, finished in a prison. And people are talking about not of deinstitutionalization, but of trans-institutionalization, because the people who were previously in a mental hospital sort of shifted into the prisons and were kept there for varying amounts of time, very often on multiple occasions, because as soon as they left the hospital, the prison, they were again committing something. And by that time, they already had an indication that they were previously in the prison. So it was even easier and normal to, so to say, put them back into prison for a while. The principle of community care, which has been very clearly stated, has in fact become a bit difficult because so many communities did not care. And not only that, but it's also important to recognize that the last 40 or 50 years have been marked by very rapid and major social change, which was due to urbanization. Today, you have a country such as Argentina, in which 94% of the total population lives in towns. And most of the people who came to live in towns have, in fact, appeared there on the doors of the towns in the last 20 or 30 years. They come on their own. They don't know other people. They don't know what the town is all about. And they certainly are not a community that is helpful and help other people who are mentally ill or in other ways unwell. They don't have family relations, which are usually in extended families. There were numerous members who were living in the same geographical area, and they could all contribute and participate. But these very large families in urban settings have started becoming smaller and smaller. There's families where very often a 3-member family or a 2-member family, sometimes with an extra grandfather or grandmother who were left over from somewhere, very often, however, living separate from them. And the idea that they could accept another patient to look after them alone was not particularly popular. I live in a town now, and I live in a house which is 10 stories high, and we've been in this house for 10 years. Now, in these 10 years, I have met, and usually meet, one person, and that person is, I meet him because he takes his dog for a walk early in the morning. And I usually go to the office at the same time. So we meet in the elevator and we say hello to each other and ask him how his dog was doing. And he tells me that the dog is doing fine. And by that time, we have arrived at the ground floor, and he goes and walks the dog, and I go somewhere else. Now, that's not a community in which I can, for example, had a bout of schizophrenia, it is extremely unlikely that he would leave everything and start helping me. And the other people in the house, I don't even know them. The community, which was originally described by people such as Griesinger, for example, in Germany, who in 1842, having come back from Egypt, was impressed by the fact that when somebody was ill in Egypt, everybody in their surrounding, a large family, as well as everybody in the village, was very concerned to do something and to help him. But the communities of that type that were present in villages at the middle of the last century, the 19th century, have disappeared. They are not there anymore. In large towns, there are no communities in which people know each other, are willing to help another, have long-term relationships, go to each other's marriages, go to each other other celebrations, etc. These communities have by and large vanished. So this is a situation which is very different from the principles which we had in the 1950s and 60s and 70s. The social institutions, the social homes, which I mentioned earlier, and similar institutions which have different names, have been very often misused. In some countries, they have forbidden the people who are in the social homes to leave their social homes, because when they left their social homes, the owner of the homes would not receive the money from the government, which was given for care of people who are present in the place. So they were locked up in the social homes without any care. Many of the social homes had no a permanent doctor or other medical person who was present. Tuberculosis was rampant in some of the countries' social homes without any control for it. So that these social homes have been misused very often or mismanaged and have not done what people were hoping they would do. The joint families, which were previously composed of 3 layers and of many other friends, etc., who have been mutually supportive, have vanished and have been now replaced by a very large number of very small families, which we see everywhere. Not only have they been replaced by small families, but they've been also replaced by a number of people who are living alone. In London, in a recent, relatively recent survey that was done, people found that 26% of all households were single-person households, a person living alone. And in a number of other countries, for example, in China, special legislation has been issued punishing the children if they do not look after their parents sufficiently well. If they are living in the same town and they leave the elderly parent of one or the other member of the nuclear family on their own, they don't want to go there, they don't have the time to go there, they have many other tasks and duties, and these people are neglected. So the government decides what they will do. They will pass a law which will punish them if they don't do it. A number of other countries do similar things, even in countries which are poor, poor being low income. For example, Bangladesh has recently passed a law as well, in which the care for the parents is an obligation which has to be fulfilled by the children, or else the children will be punished. But that is an important situation in which we are finding ourselves, that these previously large families, which could without any problem accept yet another person, have by and large vanished in most parts of the world, even in very poor places. Very poor places, I say, well, these are countries which have low income, in which many people have moved into towns, slums, and live in the slum surroundings. And the slum surroundings very often do not have large numbers of the same family, but have many families. They know each other and live close to each other, but the obligation and the sense of duty that people previously helped to help one of their members who is unwell has by and large vanished in those settings. Most of the urban dwellers avoid contacts with others living next to them. They are afraid of them. It is not least also to mention that many of the people who are moving to towns are in fact what one would call inter-country recent migrants. And migrants always have a big problem to establish themselves and to establish contacts with the local population. And they're certainly unlikely to accept people whom they don't even know and to look after them in a setting. Now, it is not to say that there are not corners here and there in some of the countries in which the communities are a little better maintained than elsewhere. But in the large majority of countries, there is a continuous process of disruption and diminution of the size of families and the disintegration of what we previously knew as a community. The consequence of that is also that despite of all our efforts to train the general practitioners and to do something for the various people, still about 4/5 of the total number of very serious people, serious mental illness, is in fact not receiving any treatment at all. But what is even more important at this point is that in the highly organized and highly developed countries, which are of high income, 20 to 25% of the severely mentally ill people do not receive care. Because even the government has its limits to which it wants to go, and there are the carers as such are not, the community as such, which could receive people and give them all sorts of help, very often is not prepared to do it. There are, of course, some promising developments as well at the same time. In some countries, for example, the peer support has been gaining strength. It has started the peer support with people who were addicted to drugs or to alcohol, and the Alcoholics Anonymous and similar organizations have been doing a very useful work. They have been helping one another, and they have been taking sort of responsibility for one person to help them to overcome the crisis, etc. And similar peer organizations have now sprung up for diabetes, for cancer, and for certain mental illnesses. And these peer organizations are doing a wonderful job. I must say, the peer organizations are done by peers who are not getting any money for it. They are sacrificing their own time to help these other people. There is even a world organization of peer support organizations which tries to organize, and that is a very promising development. But it's not a solution by itself. While we can hope that some of the peers will help some of the people who are mentally ill, that does not cover the large majority of people who are living this. Not to forget to say also that the doctors as such are very often not particularly close to the peer organizations. We have been working in several countries trying to revise in Central and Eastern Europe, trying to revise the services. And one of the difficult tasks which we had was that the doctors who is discharging the patient should not only know who the peer support organization is, but also that they should give them the patient the address of such an organization, to ask them to go and see them, to phone the organization and tell them there is a gentleman who's just coming out of hospital, would you be interested in helping him, etc., etc., etc. Now, I think that the difference, another possible thing that is very positive is that, in fact, in some of the families in which people have in the past very often shied away from the person who was ill, they have now found a way, particularly with modern treatment, to look after such people, and families have become, although much smaller, have very often been willing to sacrifice a lot of their free time, energy, and effort to help the people who are mentally ill and who have come home. The medications which have been used for psychiatry are cheaper and cheaper, and although they play only a part of the role, they're important to have them as well. And today, it is in fact for most countries possible to get these medications. In many countries, we see that the medications are offered free of charge, which is also very possible. The efforts to train general practitioners and other primary care agents have been successful in some countries, not in every instance. Very often it depends on the personal inclination of the primary care agent, whether he or she will want to do something with mentally ill people or whether they will in fact reject them. An interesting reflection of the stigma that is very much at play here is also that some of the psychiatrists whom I have met, for example, in Thailand, have their plate of their name as a general practitioner, although they are fully trained psychiatrists and trained psychiatrists and treat psychiatric patients as if they were in a psychiatric hospital. But neither the doctor nor the patient wanted to be known that they are having a mental illness which is being treated in this situation. There has been a gradual development also of the ideas that something has to be done about stigmatization. Stigma is one of the most serious and terrible problems on the way to any improvement of health care. In fact, the recent Lancet Commission report on stigma, which is freely available and certainly an excellent piece of writing, has reviewed the situation in many countries and without any doubt demonstrates that stigma is still the number one obstacle to making significant progress. This is the Lancet Commission was a thing done by a variety of people, psychiatrists, people with experience of mental illness, carers, and other doctors, etc. But in addition to this, there is now, at least on two occasions, 3 years ago or 4 years ago, before COVID in Holland, and then more recently in Paris, the ministers of health who have come together to speak about the progress of healthcare in general have recognized that the battle against stigma is a priority and have spoken about that and have done some of the work necessary to do this. And we are now also gradually saying and knowing that the public health importance of doing something about mental illness is generally recognized. People know now and believe us that this is a big problem, which was not the case about 50 or 80 years ago, when it was considered that only a few crazy people are moving around and that is not a serious problem. The calculations which are being presented, of course, are clearly showing the enormous loss of productivity and other losses that mental illness produces. But at the same time, our argument that they are very mentally ill people is turning against us in a way, because the fact that there are so many of them around, in a way, says that the mental health system is not particularly effective in reducing their number. So that the argument there are 1 out of 10 or 1 out of 5 people is mentally ill is all right, but has to be accompanied by additional explanations, lest it be felt that mental specialists and mental health services are not very good at doing anything useful. Now, having said all this about the situation at present, I think that we should probably think about what could be done in mental health care this year, now, immediately. Here are some of the things that many people have been speaking about. I think that we should not any longer speak about treatment of mental illness in vague terms, but should provide equally specific calculations as they are provided for any other public works. We are very often saying it can be done, but I mean, it's not can be done. One would have to say specifically how much it costs, where the cost comes from, how it should be handled, and what management we are proposing. We should stop thinking that we can get rid of all of the institutions, because some of the institutions for inpatient care are necessary. People, when they are acutely ill, very often can be better treated within an institution that is manned or that has personnel that knows what they are doing, and such institutions should exist and should be controlled very carefully for the quality of care that they provide and for the respect for human rights of people who are accepted to these institutions, but they are necessary, and they have to be one part of what Professor Thornycroft and others have called the balanced care system, in which we have a variety of institutions that work together. One of the tasks that has to go in parallel with this is to review the legislation which is related to mental illness. It is by and large worldwide very obsolete. There are very few of the mental health laws which are really up to date, and mental health laws which in fact contain what we now know about mental illness. And these legislations in some African countries, for example, they are almost exact copies of the mental health laws of France in 1888. Now, this is more than 150 years ago. The world has changed so much that it's quite clear that these laws make no sense. Very often the laws are simply transcribed, and that means that they will not be useful. For example, there is a rule to protect the human rights. There is a rule that 2 doctors have to provide a signature if a person is to be admitted to mental hospital or mental institution against their will. But in spring, the distance between the first doctor and the second doctor is maybe 100 or 60 kilometers of mud. And they cannot get together to have 2 signatures put on the piece of paper. So this particular prescription, which was all right in a town in France, is not applicable anymore. And it is silly to speak about this because they will either falsify the signatures or disregard the rule and proceed to do something to help the patient, to treat the patient. And there are numerous other things that have to be done. I always tell the story, which I think is so illustrative, of Spain, in which some years ago we went to see and we spoke to the directors there of the hospital and others, and looked at these institutions. One of the things that was prohibited was the eating of cheese in the hospital. The hospitals had their prescription for diet. We have examined those, and there was a prescription that there no cheese should be given to patients at all. Yet Spain is a country in which there are wonderful cheeses, and the people like them and eat them as part of their normal diet all the time. We have tried to discover what it was, and finally we discovered, yes, this was because about 50 years ago or so, some of the medications that were used for the treatment of depression, MAO inhibitors, have in fact had bad reaction if they were eaten together or taken together with cheese. Now, the MAO inhibitors are make of the past. They don't exist anymore. But the rule is still present from over there for many, many years. And I think that if you go through the rules of hospitals and rules in the systems of care in many countries, you find a number of obsolete prescriptions which are disregarded. And the consequence of this is, however, that since the people look at the law and the prescription and see that many things are not paid any attention, they don't pay attention to any one of them. And many of the misuses of legislation and rules are due to the fact that these laws and legislations are obsolete and not controlled or not updated for many years. So my notion is in the legislation for mental illness, which is in an area that develops very quickly, one should think about a sunset clause. That is to say, this law is valid for the next 2 years. In 2 years' time, we shall examine this law to see whether anything as new has happened which can help us to make the law better, to improve it. It's very important to do this because sometimes the mental health laws will be in the making for many years. And to get it back on the agenda of a parliament is very difficult. The law on mental health in China took 22 years to be developed and approved. And if you want to change it, it may take another 22 years. It's a good law, but it may be something may have to be changed in the now or later, whenever. And these laws will then take a lot of time before they can be changed. Now, we should also think another thing that is now becoming a priority is training of healthcare and other professionals about mental health early on in their training. And this is not a training which should be done as we have done in the past. One of the features, for example, should be that we should train various participants in the treatment of mentally ill people, various participants together. There should be a part of training of the doctors which is joined with the training of nurses, of social workers, and others who participate in training. Why? First, because they have to know the same thing. And second, because during the joint training, they will probably learn how to respect one another and work better as a team. And it's something that is easy to do, and very often, particularly in conditions where there are not too many good teachers, can help both the quality of teaching and the relations that subsequently happen. Now, to my taste, one of the chief priorities in the years that come before us is that we should think about providing more care and more support to carers. They are, in fact, the people who carry practically all of the service, not the community, the individuals who are in the family, one or two people who very often sacrifice their life to help somebody who is unwell. The number of, as I told earlier, the families have decreased, so the number of carers is smaller, and it's one woman who looks after maybe a husband who is not very well, and at the same time also an elderly father or mother who is slightly demented, and many other things in addition to everything else. It's a huge amount of work that is put on a very small number of people. Their numbers is very small, and what we know now is that they are more frequently physically ill. We know that they are, in effect, the care as such, the outcome in many instances, in many places of mental illness treatment is worse than it used before, because the care which is provided by carers is incapacitated by the burden on which people, under which people rely. And of course, that increases the cost of care. But there's another aspect of what we could do about the carers. We should think a little bit about providing carers also an opportunity that people know that that we respect them. Why do we not, for example, regularly, and that is a rare thing that we are seeing, why don't we invite carers to teach students about care for chronically ill people? They know much more than any doctor will ever know, unless the doctor had a mother or a father or a brother or a sister who were not well and had to be looked after at home. And this is never the same, because these people, the doctors, they themselves have other resources and very often more money than most of the families whom they treat. So why not invite these members of the families to come and teach students, speak to them, explain to them how they in fact have to look after people who are mentally ill. I've been surveying most of the countries of Europe to see whether there is any one in which there is a rule which says what must be the strengths of the family into which I'm discharging a mentally ill person. What is the minimum requirement of free time and of money? Because if I don't know this, if I just discharge the patient into the community doesn't care, the family cannot tolerate it, and very soon the patient will be back under worse condition. So the notion that we should have rules about what is the minimum strengths of a carer group that can receive a patient is something that could be and should be done very soon. We should, in fact, also recognize that there are various other things that we should mentally accept. We should understand that most people in the world do not live in mutually supportive communities, and that we have to think of a new structure in which we are working very closely hand in hand with the carers. We assess their capacity, we help them, we respect them. It's only the British Royal College of Psychiatry which has an annual prize which they give to the most respected, most effective carer family. And I think it doesn't cost very much to do something of that type, to have at least among the people who are there some sign of recognition of the tremendous effort that families and carers do. We should also not only assess the capacity of carers, but we should help them in concrete terms, in money. In some countries, there is a small amount of money that is given to carers to look after the patients at home. After all, they are taking the role of the hospitals. So it would be logical that the amount of money that was spent in a hospital for looking after a patient should now go to the carer who is looking after that same patient. In this instance, maybe the carer could hire somebody to help or could reduce some of the extra work which they have to do anyway, or in some other way, he would at least feel also that he's respected, that his work is worth something. It's a tremendous contribution that family members will make looking after somebody. So we have to give the money or other support. There are some instances which are very beautiful. For example, in Holland very recently, they've changed the role in 2 districts of the social workers. Social workers are no longer having a room in the hospital. They are in fact giving care of 15 families. And they have to go from one of those families to another. Every day they have to see them, talk with them, help them to look after the patient, help them to deal with social problems. And in many families, they are seen as a son who is very knowledgeable, welcome at all times, and who helps them very much. We were wondering whether, in fact, the social workers will be willing to do this. And the reports which you get from these social workers, they are delighted. Suddenly their work has become a real work what they were trained for. They're helping specific people and they are becoming members of that family. It's a wonderful experience, they say, and they like it much better than the previous style in which they were advising people about this, that, and the other, and dealing with the authorities only. Not coming into the place where they got a cup of coffee and sat together and talked about things and being an able member of that family who can and does want to help the person who is not well. I put it down here on this slide to say you should make money follow the person who needs care. It's not that you can keep the money and expect that care will continue. Somebody has to pay for it. And if somebody has to pay for it, we should think of ways in which we can support the person who does it so that he can continue living a normal life while helping people as well. A new problem that is emerging as well in these years is the problem of thinking how to help people who have comorbid disorders. Many of the people who have mental illness also have physical illness. Where are they treated? Very often there is nothing that is done about that. And they are very often suffering from both the physical and the mental illness. Collaborative care, which has been mentioned as an answer to this problem, works if the chief of the Department of Internal Medicine or the general practitioner is a good friend of the psychiatrist, and they can call each other. But otherwise, collaborative care is very often present only on paper. The Americans have even started introducing a new profession which will take the patient from one doctor to another when they have comorbid disorders. They call them care managers, because care has to be managed by somebody. So the notion that we should think of a different way of dealing with comorbid disorder, because up to 1/2 of all people with mental disorder also have a physical disorder, and vice versa, of course. And I think that that is something that has been neglected for a very much time. And as I mentioned earlier, it would be nice to think of some training that is given together to doctors, future doctors, medical students, nursing students, lawyers, and others who participate in training, policemen. Many of these people, in fact, should have a joint experience in meeting the other actors, finding a way to treat the policemen as a separate program costs money and time. But inviting some of them to come along for some of these training hours is very much easier and works equally well. I think that I mentioned the terms of employment of social workers, which are particularly important in thinking about the life of the person after he's left the hospital or wherever he might have been. I think that the continuous effort to think about ways in which we can reduce the stigma of mental disorders must be an effort. We have recently published a book in which we have reviewed the current knowledge about stigma and fighting stigma. And we were amazed in writing this, how many useful cheap things can be done to reduce stigma. And I think it's a very important permanent duty of the mental health service to think of ways of reducing stigma. Not having campaigns. We have a campaign against stigma. No, because the campaign comes and goes. And after the campaign, people who are involved are feeling even more dejected and alone than before. It must be a permanent, continuous process of thinking about ways in which stigma can be reduced. And of course, it would be useful in thinking about all this to also listen to people who had mental illness or their families. What would you like most? We have done a survey some time ago, building a program in Canada, and we have done all sorts of things. In the news, in the streetcars, there were various posters, and there was speeches on the radio, etc., etc., etc. And then somebody said, "Well, wait a minute. Let us ask the families to see what disturbs them most. Is it what people think about, or what is it disturb them?" And we went to the families, and the families told us what really disturbs us about the fact that my son or daughter has a mental illness is that when we get to the hospital doctors treat it as if we were dirt. We are seen last, we are waiting longest, all sorts of things. So we went to the hospital doctors and said, this is what complaints we hear. And they changed. And the families suddenly were feeling much better. They said, wonderful, they're willing to work further with us, etc. All of our stigma program that we have started at that time was much secondary to this one particular thing, which we managed to change and which opened the door to other things that could be done. Equally so, we should invite carers to help us plan our services, to think about, there are so many stupid rules that still exist. I know a particular thing was recently seen a plate that hospital, it was a mental health ward, and visits were permitted between 3 and 5 on 2 days a week. Why 2 days a week? And why only between 3 and 5? I asked them. They said, well, that was always like that. But that's not an answer that you can accept any longer. What was previously perhaps, for one reason or another, justified, has to be changed if the world has changed. So, ladies and gentlemen, I think that it is fair to say that the arrangements which we have currently about help with people with mental illness, and particularly also about helping carers, are obsolete. I think that the fact that the traditional communities have changed and disappeared, and that the urban living is now the main form of living, requires a revision of principles which we are using in mental health care. And some of the key elements in this is support to carer, which must be a priority for action, particularly for chronic illness. Development of new types of care, such as the peer support, common dwelling, the Australian example of safe spaces, many other new and interesting features. We must insist that the funds should follow. Care outside of the hospital is not cheaper than in hospital. It is equal cost. So we have to think about cost as well. And I think that we should also remember that we cannot have rules which are valid forever, and that we should think about changing rules very soon, every 2 years or every year, to make sure that we are in keeping with time, and that we can, in this time in which we are living, have rules which are useful for service, for our patients, and for ourselves. Thank you very much for your listening to me.
Yeah, hello. Are we all back again? Thanks. Thanks, Norman. I think Sujit, I think you're there.
Yeah. Thank you so much, Professor Sartorius. This is actually, in fact, an eye-opening message for the audience. I want to discuss about a typical scenario in the developing countries, particularly the South Asian countries. Most of the South Asian countries, including India, they struggle with the number of mental health manpower. There is a paucity of manpower, and people struggle because of not having adequate psychiatric nurses and ancillary mental health manpower. So the number of psychiatrist seats has been increased by the government, and But unfortunately, what happens at the end of the course, many of the psychiatrists, they leave the country and go abroad. They want to practice psychiatry in developed countries rather than staying in India. So even if the number of psychiatric seats are increased, there is a draining of psychiatrists from the country. And this is not a unique problem to India. That is also happening in Sri Lanka. That is also happening in the other region like Bangladesh, Pakistan. So how to deal with this issue so that the manpower shortage can be addressed adequately?
Well, the first thing that you have to realize is that doctors, psychiatrists play a very minor role in the treatment of mental illness. We don't need them for as long a time as people think. What we do need is to really think of who provides care, and that is the carer. And we should think about how we can maintain the system of care by people who are with the family, etc. The doctor, we can do with even fewer psychiatrists than we have now. But what we cannot do anymore is we cannot do without the supporting people, or people, their brothers, their sisters, their family, others in the community. These are the ones who carry the disease burden nowadays. The doctors give advice and they don't see the patient. You see, as a psychiatrist, you see the patient, as I know India, when I was working there, I saw it and it's not changed very much. Most of the doctors see the patient for control about 5 minutes every month, or 10 minutes maximum. Well, a month has many minutes. We are paying attention to the doctors. We are not paying attention to who in fact does the care. And that is the switch which we have to understand. Now, you say many doctors go away, go to England. That is unfortunately a process, not to England, but to some other country, Australia or wherever. That is unfortunately a negative consequence of training people. The people in developing countries, in the lower income countries, have been supplying doctors for the world now. Although they are poor, they give all the doctors. Most of the places in the world are now full of people who have been trained at great expense in India or wherever else. And I don't think we can change this, but we could change what happens with those who are at home, what happens with the community members, not the community as a whole, because as I said, community as a whole has changed in its nature. It's not any longer as cordial and as close as it used to be.
Thank you for your comprehensive answer. Maybe we can take some few more questions from the audience.
Yeah,
Dr. Renner is having a question.
Yeah, I invite others as well, but so I keep my questions short. So what about the, Norman, you just talked about mental health in general, but I think what we see very often is, we have, I think due to the medication, things have changed, and sometimes the support is much shorter. So you can have people who are treated for a while and then it's shorter, and the medication has done a lot of that. So if you can comment on the differences of the diseases and what they differently need in this model. And the other thing is, I'm currently having the experience of being just involved in the care of my parents. And interestingly, my father, who's 88, now has to organize care. And what he's really struggling with is all this paperwork and the numbers he has to put on the computers and all this stuff. And he has commitment for my mother, but the management is extremely difficult. And I think there's lots of admin stuff. And I just visited the nursing home, and going from one place into the nursing home looks simple, but it's an administrative burden, and so everything is extremely complicated in the administrative side. And I think this is part of our society. So what would you recommend on that?
Well, it's a wonderful example, I think, of the problem which is currently becoming obvious. People live longer, but they don't necessarily live a happy, healthy life. They get sick, they have diseases, they have more diseases as age progresses, so they become increasingly dependent on someone. is quite clear that the doctor plays a role there, but the main role is not the doctor anymore. Here again, it's the carer who needs support. There's wonderful work that Dr. Brodati has done in Australia about what needs to be done to keep the carers alive, to keep the carers functioning, to keep the carers healthy. It's not easy, but I think that is probably where we have to think. But there are other things now which we could or should emphasize. For example, most of the elderly people, speaking about the old age as one example of that, most of the elderly people, in fact, are finding it very difficult to use electronic devices because they are very complicated, and they are, for them, it's learning a new language. And you get this stupid advice on a variety of QRs and God knows what. They don't know what to do with this. So one of the lines of action could be perhaps the modern technology could be developed keeping in mind of who will use it, rather than to develop it because the most advanced people in the world can use it better. So I think that the emphasis on development of a simple technology that can be useful. I give you an example of simple technology, which I thought was wonderful. They have in Denmark, they have put now a small wire into a little carpet in front of the carpet, a mat in front of the toilet of people who are elderly. And they expect that people who are elderly will step on that little carpet when they are visiting the toilet. But if they do not step on it for more than 8 hours, a bell rings in the service and says this person is not replying. So they can call him. So instead of waiting for 3 days half dead, he gets a call within 6 hours that he hasn't been to the toilet. And I think that the notion of having such tools, using the current technology which we are having to help people live, even when their condition, when their capacities are diminished, is of tremendous importance. I think equally so, one has to help the, I mentioned already that in your instance, you were, maybe because you are working as a well-conditioned doctor, you can afford help of other people. It's expensive, but it can be done. But in many other places, we should think, can people afford the care? And if they can't, we should in fact consider it as normal that they are paid for what they're doing, not an exception. In some countries, they get a ridiculously small sum, which they are supposed to do it. Yet they're providing service which is equal to the best hospital service in the world. And we are saying, well, this is normal. It's not normal. It used to be by necessity normal. It's no longer that. Now that people are working outside of the house, it is normal to expect that expenses have to be covered and help them, particularly in a society in which everything is measured by money. And the care is no longer possible that the minister says we are looking after everybody and my staff are wonderful. He should also pay some money to help these staff survive. So my sense is we should use the modern technology, if at all possible, to a degree. We should recognize the need for care and the need to help carers as such. And we should also revise our instruction manuals, which govern what we are doing about people when they're not well. And multimorbidity is a huge problem that sort of sits above everybody, because your father maybe is lucky to have only one problem, but most people have a cardiac proposition, a prostate that doesn't work, and 100 of other things for which they have to see somebody and do something about it.
Professor Roy Abraham is asking a question. Over
Yes.
to Professor Roy Abraham, sir.
Yes, Professor Sartorius, you have dealt with a lot of leadership in the world, political leaders. I would like to know from you, what's the best way? Is there any easy way to get the attention of the political leadership who makes most of the decision in the low and middle income countries? I remember I myself had an experience. I was the president of the Indian Psychiatric Society. When I obtained a session with the Union Health Minister at that time to speak about mental health problems, it was possible because my local MP, local member of parliament, was a friend of mine. I was treating one of his close relatives. And this MP happened to be in the parliamentary committee for the health ministry. But unfortunately, myself and my delegation were sitting, he made some cursory remarks. Then there was a TV playing in his room, and his attention was on the news being scrolled there. So we had 30 minutes, probably he was listening to the TV news. He hardly paid any attention to what we are saying. Finally, he received our memorandum and said, I will do the needful. But nothing was done. This is not an isolated experience. This is how politicians deal with in the developing world. What can we do about it?
Well, number one, we should think of working with politicians as one normal part of our life and working hours. It is more useful to spend 2 hours with 5 parliament members than to see 25 patients. Because the 25 patients can be seen by people whom you have trained, and they can also be seen for a shorter time while you are thinking about ways in which the politicians and people in the government, etc., can be gradually attracted to the area. I'll give you one good example. A few months ago, one of the most extraordinary events happened. The United Nations have passed a resolution specifically directed to improving mental health in the world. The United Nations, first resolution since the United Nations came into existence. It's a 7-page resolution. Everything is in it. I asked at a recent Congress in Vienna, I asked about 40 of my colleagues. Not one of them knows that the resolution is out because they don't care about the United Nations or about whatever other organizations there are. And one should probably understand that the role of a doctor is to a large extent also of a role of an advocate for his people who are sick. And therefore, if you're dealing with politicians, you must use the same weapons which they are using. They talk about resolutions and decisions and laws and other things. And psychiatrists very often neglect to speak the same language and to read the right documents and to go to them and speak. It means that they have to take part of their time, maybe half of their time, to learn all these things and bang on the door of people in order to do something about it. It's particularly true this is for primary prevention. Primary prevention is entirely in the hands of mental disorder, in the hands of other people. Take the example, iodine deficiency in pregnancy leads to cretinism. All right? Now, none of the psychiatrists will ever go and give iodine to women. But it is his duty to make the bloody government, in fact, provide and show that they provided iodine to all pregnant women. But to do this, he has to bang on many doors, and he has to be much more of an advocate for his people, so to say, than is currently often the case. In a more modern situation, the tribune, the fellow who is looking after patients, must become the psychiatrist who is the agent who links the government lines with the needs of people who are mentally ill. In addition, he has to look after patients. But in addition, I think he must make sure that the government as a whole, or the society as a whole, provides the wherewithal to look after these patients, because otherwise he prescribes a medication and the patient either takes it or not, and that's the end of the story. They don't get well. The disease does not stop in a moment. The disease is there all the time. Looking after the disease is now becoming the least important part of one's work.
Thank you.
Dear Professor Norman Sartorius, thank you very much for your amazing lecture as always. So it's my honor to be here, and I would like to thank you for emphasizing the topics about psychosocial workers and the role of psychosocial rehabilitation, which really should take enough time in the treatment programs for our patients suffering from any disorders, either stress-related or psychotic heterogeneous disorders. And absolutely agree with you about the need to have advocates who would protect people suffering from mental illness. I'm working with my chancellor in the university, who is a surgeon, and I was appointed at my position 2.5 years ago. And finally, only after 2.5 years, he started pronouncing the word depression and anxiety in front of the council. And he started talking that we need to do something for people with depression because depression is rising. So I was absolutely impressed that finally I hear these words from the surgeon, from the chancellor, and he really started helping us with psychiatry. And recently we've been to Uzbekistan, and the president of Uzbekistan, by the way, Professor Shahnaza, send you greetings.
Thank you.
And yes, and she had very good reminiscences about your visit to Uzbekistan many years ago. Yes, and when president visited psychiatric hospital, it changed a lot. So they have impressive environment, and we visited this hospital, and they have everything: rehabilitation rooms, social workers. They have no such stigma. They have not so high fence. They have terraces for patients. They have shower with she for patients, everything. So we were impressed. It was much more, much better than the hotel we stayed in Uzbekistan, the psychiatric hospital. So it's, especially when you say that we don't live anymore in a mutually supportive environment, it's very important now to advocate and support our patients who are suffering from mental illness. And I met Professor Miro Yakovlevich, who, of course, a big fan of you. And he was discussing his idealistic concept, but I like it very much, about empathetic civilization, because he thinks that it will help against mental illnesses in the world if we continue to support each other. If I still have a question, I would just like to ask about gender-specific services. What do you think about this? Because now we have also issues with gender choice and gender education and so on. And also we have a gap, and I know that European Parliament is now have suggestions from psychopharmacologists to change instructions for pharmaceutical drugs, which would be subdivided the prescriptions for females and males, because they are different, and really women and men differently react to pharmaceutical drugs, and have different issues about immunity, because the genes which are responded for immunity is an X chromosome, is located in X chromosome, and so women have more immunity, more efficient immunity, but they also develop more autoimmune disorders. So it should be taken into account when we are providing any types of treatment to females and male population, and specifically in psychiatry, including side effects and safety. Sorry for many words.
Well, I think what you said, which is one thing I didn't emphasize very much, it is the need to establish a different relationship with our colleagues in other disciplines. For the moment, they consider us that we are the least knowledgeable and the least helpful people in the world. And sometimes they are true, they are right, because we have forgotten that medicine has developed, and we have concentrated on looking in psychiatry only, forgetting with theories like psychoanalysis and others, forgetting that science, meanwhile, is advanced, and we have not been able to speak to our colleagues in internal medicine and whatever on the same level, understanding the modern science of medicine as well as they do. So it's very important that we gain their respect by being up to date. And it's something that psychiatrists should be thinking about very carefully, because many of them are not really up to date at all. They know psychiatry of 20 years ago. They're very good at that, but the rest is being neglected. Maybe I think that I have another hope, speaking of gender, which is the current in a number of countries, the number of new psychiatrists is predominantly females. And my great hope is that they will improve psychiatric care greatly, because they may have more empathy and more a feeling of somehow of the need to look at various aspects of human life than the males had in the past. So that is a good thing. Particularly Turkey, I think, has been a good example where there are two disciplines which are everybody gives priorities. One is psychiatry and the other one is dermatology. And when asked about dermatology, they say, well, we have to do dermatology because there are no night duties in dermatology and we have small children, so we want to stay with the children. But psychiatry, no, psychiatry, we want because we feel that it needs more of a sense of feeling, and that's why we want to do psychiatry. Our male colleagues are not doing so very well. So there's a hope in that maybe that this extra talent of our female colleagues will also be very helpful in thinking of an emphatic way of producing mental health care.
Thank you very much, dear Professor Sartorius. Thank you.
Okay, thank you. I think we thanks a lot for all these contributions, and I think we might go over to the next speaker. I think he was one of to be here today, and Christopher Sabo. Do you mind you sharing your screen, or you're sharing your slides?
I'll do that.
Right, and maybe Sujit wanted to say a few words.
Professor Christopher is a professor of psychiatry at Department of Psychiatry, University of Witwatersrand, Johannesburg, South Africa. He was the editor-in-chief of Global Psychiatry Archives from 2018 to 2023. Previously, he was also the editor of African Journal of Psychiatry. His areas of interest include eating disorder, ethics, leadership, and adolescent psychiatry. Over to you, Professor Christopher, for your presentation on psychiatrist as a podcaster, personal reflection.
Sujit, thanks for your introduction. Thanks to Rainer for inviting me. I'm not sure he'll thank me after this, but this is going to be a little bit of a story. It's a personal story, and it's about an experience that I've had in recent times. And when Rainer invited me to do a presentation, I thought this would be something that would be a little bit different in terms of what others would be presenting, and also provide some kind of insight into this, well, one could call it a new technology, and its interface really between education and technology. And I think the podcast represents a very interesting development in that. And so I'm going to take you on a journey, my own personal journey. So please, but don't think of me as egotistical. This is not about me. It's about the journey. And for any of you who would be interested in becoming a podcaster or hosting a podcast, hopefully I will give you some insights into what that entails. So the first thing is obviously, what is a podcast? And I think that many people who listen to podcasts or are consumers of podcasts have a clear understanding of what it is, but there are many people who don't. And essentially, it's a bit like the radio, but it's not. So obviously, you don't switch on the radio to listen to a podcast. You log on and it comes to you via the internet. And so basically, it's a download. It's a stream. It's streamed to your device, be it your laptop, computer, or your cell phone, either way. And the issue here that it's available always, and you can listen to it anywhere at any time. I think it's very accessible and very convenient if you have the technology, obviously. So in essence, it's audio, but it can be video. And usually a podcast is on a specific theme, and you will get to hear what my particular podcast was about. Those who podcast are called podcasters. One thing they say, though, is that it's simple to create. I'm not so sure that it's simple to create, and I think you will see exactly why as I walk you through all the different steps and I show you the role players, and I name names for the sake of completion in terms of who they are and who they were, also to acknowledge them. So just to put it in perspective, as of September 2023, there were supposedly over 3 million such podcasts available, and some think it actually over 4 million. So when you produce a podcast and you put it out there, you've got a lot of competition in terms of the audience that you're potentially vying for. To give you some perspective in terms of podcasts, the top 5, maybe you have or haven't heard of Joe Rogan. If you haven't, okay. If you have, welcome. He has 11 million listeners per episode. That's a lot of people. If you look at the next 4 combined, they don't actually add up the number of listeners he has in per episode they have combined. And you can see, in fact, the numbers 2 and number 5 with crime. So there's a kind of a preoccupation with crime for podcast listeners. But Joe Rogan is the quintessential podcaster. He's the benchmark, and he is an interesting guy because his podcasts last over 3 hours, and they are really conversations that are very deep, but also move in all sorts of different directions. So if you haven't watched a Joe Rogan podcast, it's well worth, and you'll be surprised who he interviews, in fact. So just to put it in perspective in terms of what a successful podcast might be, if you get 3,500 downloads, you're in the top 10%. Remembering we're talking about a 3 to 4 million base of podcasts. If you get 9,000 downloads, that's 9,000 people who download the podcast from the internet to listen to it. That'll put you in the top 5%. And if you get 50,000, you're in the top 1%. Joe Rogan gets 11 million. That just gives you some perspective on how people download and what success might mean in that sense. Although success is a relative term. The reality, though, is that only 60% of people actually listen all the way through. There's a big attrition rate in terms of podcast listening. But I think what is important is that if you engage listeners who are really interested, they can have an impact. And I think what is important about podcasts is to put out quality content, but release new episodes on a regular basis, because your audience moves on very quickly. You have to know that you're in a very competitive market. And I think that one has to be very careful not to be numbers driven. Because if you're numbers driven, you lose the potential impact of the people who listen, who then actually influence others around them in terms of the content. So I'm just going to walk you through quickly the idea, the finished product. So obviously for me, it was a novel experience. I have no training. I've done a lot of media work in terms of television, radio, and being interviewed, but never actually having to host an actual program and structure it and construct it and carry it as such. So it's one thing to be interviewed. It's another thing to actually create the content and bring people in who you actually interview. And of course, when I thought about it, I thought, well, as psychiatrists, what do? We interview people. When I see a new patient, what am I doing? It's an interview, actually. And I spend an hour and a half or 2 hours chatting to them, getting information. It's an interview. So I thought, okay, I can maybe translate the experience I have as a psychiatrist into this new milieu. Well, it's a completely different milieu, I must tell you, but the skill of interviewing is something that we inherently have as psychiatrists, even though we might not spend that many minutes, as Prof. Sartorius has highlighted with our patients. It just depends what kind of practice you have. So looking at the idea. So this concept of a pitch. For the idea to turn into a product, you have to pitch the idea. You've got to actually formulate what it is you want to do, and you have to take it to the right people, specifically a funder, because podcasts cost money. They don't happen for free. If you're going to produce a quality product, you need to make sure that you have sufficient funds to do it. So you're going to see a timeline here, which shows you just how quickly things worked. So from the 7th of August, 2021, I had my first meeting with a potential funder, who happened to be from a pharmaceutical company. And one could raise eyebrows and say, pharmaceutical industry, one has to be very careful in terms of your relationship with them. I have to say up front, they had absolutely zero input into the content and never attempted to influence who I interviewed, what we were talking about. And I was simply funded in order to produce these because they felt that it was something that they wanted to be involved in. And I think coming back to the issue of education, they saw this as something that added value to their portfolio of input into the medical discipline. The funder then connected me with someone who was experienced in producing podcasts and was connected to folk who do that. So I met with them, we workshopped the ideas, and then we started to put together content to pitch the idea, firstly, to the folk who were going to produce the podcast, but then ultimately also to the funder. So that's 7th of August to the 16th to the 24th. So within 2-3 weeks. So this is basically just an idea of what we sent to them. And I think what's important is that the podcast had a name, Beyond Madness. I decided on that title, and I'll explain why I called it Beyond Madness. I had this idea in my head about the music for the podcast, because if you listen to podcasts, there's always music that introduces the actual episode. And in my head, I had this idea of Jimi Hendrix. I like the guitar introduction, but of course that was completely unrealistic, because in order to use such music, there are licensing fees. So basically there's a library of product that you can use, music, which doesn't cost, but you can maybe get the feel of what you want. We noted who it would be funded by. And initially we were going to do 13 30-minute episodes. And basically we put down all the specifics when we were due to start. And I think what's important is that we were very specific about the platform. Very important who you choose to host your podcast. And we chose a very specific platform, and their responsibility was not just to produce the podcast, but they also had other functions, and specifically the issue of banners. And I'm going to get to that. So for the first season, we had a range of topics, and we looked at genetics, the biological basis of madness. We used the word madness quite a lot in the first season. But in fact, the first episode turned out to be the practice of psychiatry in a cross-cultural South Africa. And I can tell you, the first episode was due to be a discussion with myself and a fellow psychiatrist who'd written a book called Madness, Stories of Uncertainty and Hope. It was an absolute disaster. The audio failed. He was not in studio. He was phoning in. And I thought to myself, if this is what podcasting is all about, I don't think I can do this. Fortunately for me, the next episode was going to be recorded immediately after. I had the guest outside waiting, and I didn't have too much opportunity to reflect on how difficult the first attempt had been. And so that was the episode that I recorded first, which was Practice of Psychiatry in a Cross-Cultural South Africa. And I think what's important here, speaking to a South African audience and beyond, is that we were looking at traditional healers and the role of traditional healers in psychiatry, and the extent to which traditional healers actually serve a very important function in terms of gatekeeping, because patients often go there first. And so this was trying to give a perspective on where traditional healers fit in. And you can see there was a whole range of conditions, eating disorders, but also issues, spirituality in the healing process. And the podcast I eventually recorded with David Nutt had nothing to do with cannabis. In fact, it was to do with psychedelics. So the process unfolded. The platform were very happy to meet with us. We then met with them ultimately. But before we did that, we brought in another member of the team, public relations. The public relations person puts out a media release. So they need to know exactly what your podcast is, what it's about, who you are, what you're attempting to achieve. That then goes out to the media. They then have an interest, hopefully, in speaking to you, and then you start to promote the podcast in the media as much as anywhere else. And that can be television, radio, or print. So having met with the PR, we revised our pitch, and then we had the big meeting, and the team started to emerge. So now we're on 3rd of September. So literally within a month, we are sitting at the platform, which is Cliff Central, cliffcentral.com. We actually recorded the first episode on the 4th of October. So you can see the timeline, and it was released on the 20th of October. So the first episode of the first season went out literally let's just say 2.5 months, nearly 3 months after we had the inception. The first season comprised 15 episodes. That's what a banner looks like. So that's what appears on the Cliff Central platform for the podcast. So if you go onto their platform, you'll see they've got a whole host of podcasts. That's what a banner looks like, the name of the podcast, who funds it, who I am, and what the episode is. And each episode has this banner. So that's me in the studio, together with my first guest, Solly Ratamani. So at Cliff Central, see the microphone, the headphones. It's like being in a radio studio, but it's not radio. And as much as we are recording live, it's not broadcast live. It's recorded and then released. If there's any editing to do, you have an opportunity to do that after the recording. So who is the team? And I think this is what's important. Going back to the original slide that said it's quite simple to produce a podcast. First of all, you've got the studio or the platform. That was Cliff Central. Then you've got the sponsor or the funder. This was Adcock Ingram OTC, a local pharmaceutical company. Then you've got the producer, who changed from one to the other during the course of the seasons that we recorded. You've got a sound engineer. He's the guy who gives you the music, but more than that, listens to make sure that the technical aspects of the podcast are exactly as they need to be. You've got the public relations, and you've got a banner designer. And in this instance, the banner designer actually became the sound engineer as the seasons unfolded, because he was in training. You can see there are a few people involved, aside from myself, who comprise the team. So not quite so simple. This is the last banner for season 4. You can see how it evolved, and also the music evolved. Things changed. My mood changed. I felt like a change. And so the podcast also changed in terms of the duration. From half an hour, we went to 1 hour. From having one guest, we went to having 2 or sometimes 3 guests. And I think what's important is that it's not just a Q&A, it's conversation. And I think this will be highlighted as we get understanding. Now, this has got nothing to do with the studio. This was actually arising out of public relations. One of the radio stations picked up on the podcast. They interviewed me, and the program that interviewed me was one thing, but there was another program on the same radio station who decided they wanted to host me for a month, every single Wednesday, to talk about mental health issues. So it gathered a life of its own, and that was an interesting experience. So we did 60 episodes, date. There's been 4 seasons, and you can find us on cliffcentral.com, Spotify, Apple, and Google Podcasts. And we've had pretty good ratings. I mean, we're looking at 4.9 on Spotify, 4.7 on Apple. That's about as much feedback as one gets. One doesn't really get a lot of feedback. You meet people from time to time who've listened, and they will share with you. Unfortunately, it's generally been very positive. So the podcast ran from the 21st of October. The last episode, episode 60, was released on the 25th of July. We're in a bit of a pause now, which I will mention shortly. And what was really interesting for me is that we were picked up by a platform which is the #1 for Spanish podcasts, and they literally lifted the entire 60 episodes and put it on their platform. No permission requested, nothing we could do about it. And I kind of looked at, in this instance, theft as a kind of a backhanded compliment, because they obviously thought it was of sufficient interest. Season 2, you can see the kind of topics, and what's really pertinent right now, one of our episodes was about photographers and the psychological impact of being a photographer in a war zone. If we think about what's going on in the Middle East and what's going on in Ukraine, we were talking specifically to what it's like to be a journalist in a war zone and how that impacts upon you. We touched on divorce. We looked at the impact of social media on youth. So we touched on a lot of issues rather than talking about specific conditions. And in this particular season, I was kind of interested in dealing with what's it like to have a sufferer at home. If you're a spouse, if you're a sibling, if you're a family, how do you cope with that? So the theme of living with somebody with an eating disorder, or living with someone with a learning disability, or with a substance abuse problem. We then moved on to our final season via season 3. And the season has been, again, very issues driven, looking at the impact of bullying, for example, looking at childhood sexual abuse, loneliness, a very pervasive, universal phenomenon, poverty and mental illness, which is a big issue here in South Africa. We have very high levels of poverty, and not just looking at the interaction between poverty and mental illness in terms of my guests. I had an additional guest who actually owned a restaurant and had started a soup kitchen for homeless people, and their experience of homeless individuals and being homeless themselves, because they took to the streets for a period of time just to get the feel of what it was to be homeless, gave a very important quality to the podcast. And we have a huge problem in South Africa with gender-based violence. I did one of my podcasts which was focused on, in this particular instance, a horrendous gang rape that had taken place involving multiple young women, and the impact of sexual violence on the psyche of the victim. And so we were looking at PTSD in that specific instance. So we really covered a broad range of issues, but the one that we ended off with was a very different kind of podcast, because I had 3 journalists. We were talking about journalism and mental health. And once again, looking at what's been happening to journalists in the Middle East and the Ukraine, and how many have actually been killed in their line of duty in these situations. So in this particular podcast, we actually had a studio audience. So it was the first time that we had done that, and we had a Q&A session. So we actually got to engage with the audience. So this was recorded both in terms of the visuals, which is a separate component, and then we condensed the sound into a standard audio podcast as well. So that was something of an evolution in terms of the podcast. So just looking in terms of the content, just a few personal reflections. Every episode has an introduction where I set the scene. So you really need to be au fait with content. And that introduction, well, be after that. The introduction that I'm talking about introduces the podcast, introduces myself, what the podcast is about. And that's consistent across every single episode. And so that's the intro. And then there's what we call an outro, which is exactly the same, just an abbreviated version. And the music is very important, I think. It kind of creates the mood. I moved from something which was a little bit more edgy to start with to something a bit more jazzy in the fourth season, which was more the way I was feeling by the time I'd gotten there. And we used as part of the outro the World Health Organization mantra, no health without mental health. And this was a consistent throughout all of the episodes. So I think your preparation is critical when you're putting together a podcast. And so after the intro, I would then editorialize a little bit where basically I set the scene. I framed the conversation up front. I think you need to structure the conversation. There needs to be a logical flow, but there's got to be flexibility within that, because at the end of the day, it is a conversation. And then there is the take-home message, which is your outro. And I think it's very important how you choose your guests. You need to have a sense of who you're going to have. Otherwise, you might find yourself with a nasty surprise. I think it's very important that they are not simply mental health professionals, but anybody who's a thought leader in the area that you're going to be discussing. So those are my scripts. So every single episode was scripted, and I have those scripts. And those took me a while, each one. When I was thinking about what it takes to actually produce an hour of podcast, about 6 to 7 hours, maybe longer, of preparation per episode. So it certainly takes a level of commitment. What about the platform? Lessons learned. They must have the technical ability, and they should hopefully have what I call a stable of content where they are known for their podcast production. So you want to see what other podcasts they actually produce to get a sense of them. They should have an existing audience because they promote from within the platform. And of course, the support they give you and the promotion they give you is very important. And before every new season, I would go on with the founder of Cliff Central, Gareth Cliff. He's the guy on my right-hand side. And we would do a 1-hour interview where we would talk about psychiatry and mental health. And he would promote the podcast and alert his listeners to the fact that there's a new season about to start on that day. So the promotion is actually very important. So why did I do this, actually? Because I had no intention of ever doing a podcast. But I had been editor of South African Psychiatry, which is a medical publication. And what I essentially did was I converted the written word to the spoken word. Many of my guests had actually submitted and written articles for South African Psychiatry, because I think there's something different when you have a conversation. Something more comes out. Written words are static. The conversation is much more fluid, and it can take you in an array of different directions that you hadn't anticipated. I think what was also important about the podcast, and that's the educational component, the access. And I think what's important and very interesting about the podcast is that it's accessible information and it's always there and anybody can access it. Patients have families, patients have friends, patients have colleagues, they come from communities. It's important that everybody has that access, and all of these people who don't necessarily get to see or experience a psychiatrist are getting that kind of information, which could be helpful for them. So one of the so the byline of South African Psychiatry is about the discipline for the discipline. The podcast, when I thought about it, was about the discipline, but for the public. So we were taking it beyond the discipline. So why did I use the name Beyond Madness? Well, I wanted to take people behind the scenes, beyond the immediate clinical reality of what psychiatrists did, and look at some of the conversations that psychiatrists have. And essentially, what do psychiatrists talk about when they talk about psychiatry? I could remember so many discussions that I would have when I was training and after I was training with colleagues in the duty room, the nurse's station, where we would talk about patients, talk about psychiatry. And I always found those so helpful. And in a sense, I wanted to take those conversations and put them out there because I think they were also very informative, not just for me, but for anybody who might have been listening. And the one thing I also attempted to do was to show how psychiatry has implications for society, but how societal happenings, things that go on in society, have profound implications for emotional well-being and mental health. We were really looking at this interaction between psychiatry and society. In terms of what I was trying to do, ultimately, I think it's a bit of a busy slide, but the truth is I wanted to show people the richness of psychiatry. Psychiatry is not this hard, simple biological science where patients are reduced to genes or molecules. They're living human beings. And I think that psychiatry has a lot of art beyond the science. And there's a lot of thought that goes into psychiatry. It's probably, for me, the most thoughtful of all the disciplines. I also wanted to humanize psychiatrists. People have a lot of stereotypes, not just about psychiatric patients, but about psychiatrists. And I needed to humanize psychiatrists to show who they are, how they think. I think what was also important was to show that mentally ill people should not simply be defined by their mental illness. They're people. And I suppose in essence, what I was doing was ultimately destigmatizing both patients and practitioners. So you could say, well, so what? The podcast, what about it? Well, podcasts are an increasingly popular medium. As you see, there are many millions out there and many, many millions of listeners. It's accessible. It's empowering. A lot of people now get their information from podcasts, actually, not just content in terms of theoretical information, but even their news is coming through podcasts. And I think it's very empowering in that sense. Also, it's an available resource at no cost to the listener. Of course, you have to have the technology. The practitioners, trainees, patients and families. But what I found interesting is that one of the leading organizations in South Africa, the South African Depression and Anxiety Group, who do a great service to patients and their families, actually was using the podcast to train their counselors. So this was really very gratifying for me because I thought, great, it's being used because that's what it's there for. It's a resource, it doesn't cost you, take it, use it, benefit from it. So what did we achieve? I don't know, to be honest with you, practically. Very difficult to say. Did we promote awareness and create understanding? Well, Gareth Cliff, who's from cliffcentral.com, said to me, consider this. He said, because we used to get over 2,000, getting up to 3,000 downloads per episode. He said, think about you lecturing over 2,000 people in a hall every week for 60 consecutive weeks. And I began to realize, yes, that's a lot of people that you reach, actually, when you think about when you go to a conference and you lecture to people, when you lecture to an audience, that's a lot of people. And you're doing it over a consecutive period. So hopefully it had some reach and hopefully it had an impact. Did the sponsor benefit? I don't know. Did it lead to more sales of their product? Well, we never promoted any of their products, actually. So that wasn't the agenda. What was interesting is that we did get nominated for, we got the finalists in an award, best use of podcast to promote a brand or an event. We were up against serious opposition, so there was no chance of us ever winning. But to be a finalist was sufficient, and these were the New Generation Social and Digital Media Awards. So that is where the podcasting fits in, social and digital media. So this is the new media. What was achieved personally? Well, I found it enriching. I found it demanding, though. It really was, and very consuming. Because I think when you're putting content out there that could potentially influence people's lives and you're not sure who you're talking to, you've got to be very careful what you say, how you say it, the views you promote. And so there is a burden of responsibility on the podcaster in that sense. Currently, we're on a pause, which we agreed to by both myself and the team. We'll see where it goes. So will there be a season 5? I don't know. But what I'm going to leave you with is a 90-second clip that Cliff Central put together for the sponsor to give them an overview of what has been accomplished by the podcast over these 60 episodes. You'll see for yourself. I think it gives you a nice snapshot of what took place. And so sit back and here's the clip.
You're convinced, huh? அதான் ஆரம்பிச்சு போயிட்டு இருக்கு நான் செக்ரட்டரி சார் அனுப்பிச்சிருக்கேன் நீங்க
Right, there you have it. That's the presentation. So if there are any questions or comments, I'm certainly available.
Hang on.
Yeah, thank you so much, Professor Christopher, for a wonderful presentation. This is not a conventional presentation that is usually seen in conferences. This is something very new and out of the main core of biological psychiatry or psychosocial aspect of psychiatry. So this will be something new for the audience. I hope these things will be recorded and they will be uploaded, and for the audience, this will give a new message. It is quite important that psychiatrist, this is what I believe. I realized that after going through your presentation, that one way to reach common people, those who are having mental illness or their caregivers, is this is one good way of reaching their doorstep and their apps, so where they can readily access, and they can also get the personal experiences of the psychiatrist, which is not conventionally documented in the research articles. So that is something very interesting and very new for the. And I have one thing that nowadays, just like invitation for articles, different journals are sending invitation for articles. Similarly, we are getting invitation for podcast by different agencies. They refer to one of your article and they say that we want to make a podcast of it. It's very difficult to differentiate whether what is an authentic person who is doing this podcast, how that podcast will be utilized. So just trying to know that whether something like predatory kind of thing, like a scientific publication, there is a predatory publication. But there is similar kind of thing like how to know which is a authentic agency who is looking for making podcast. Otherwise, I got several mails, but it's very difficult to differentiate whether it's an authentic one or not, whether I should go for it or not.
Are you saying that you've been invited to participate?
Yeah.
I think that yes,
you have to do your something. They are charging
I think
something for that.
You have to do your due diligence, because obviously people contacting you out of the blue who you've never heard of, who you don't know about. But I think that if you were to go to any of the major platforms, Spotify, Google, Apple, you should be able to find that podcast and listen to that podcast before you consider participating. So you can get a feel for the host, and you can get a feel for the orientation that the podcast takes in terms of the kind of questions that get asked. Also, how experienced is the actual podcaster in that sense, and what is the overall experience that you have of the podcast if you're going to participate in such a podcast. So I think you do have to do your due diligence very carefully, and I agree with you. I mean, who do you know who you're going to be talking to, and who's the audience going to be? Where is it going? So I think that there is an issue of trust. So I was always very careful in terms of who I approached. I personally knew 95% of the people that I approached. And if I didn't know them, they were recommended to me by someone. And so there was always a chain of connection between myself and the guests. So I have to say that the majority of my guests were South African psychiatrists. So they knew me, I knew them. They knew my publication, South African Psychiatry, and I knew their work. The other issue is you need to know who you're inviting, because they might write very well. It doesn't mean they communicate very well. And then you're stuck with someone who you've invited, they're on your podcast, and they're very poor communicators. They stutter, they stumble, there are long pauses, they're not very eloquent, they don't elaborate, and it can be very difficult. So one has to just be very careful as a podcaster. I'm not saying that necessarily happened to me, but I can see how that can happen. So it cuts both ways. You as a guest need to know who's inviting you. You as a host need to know who you're inviting. Specifically, if you don't know the person personally. then you are really taking chances, because once you've invited and they've accepted, they're in, and then that's what you've got.
Thank you so much for.
So how would you pitch your podcast? You know, do you do it for training? Because, you know, if you really want many people, you certainly don't can focus, you know, let's say if you want to have thousands of downloads, then if you pitch it for psychiatrists, then it's getting difficult. If you pitch it for the general population, then it might be different. So we have the same problems with our YouTube channel.
Yeah.
The more specialized you get, the less audience you get.
Exactly. So I would say to you, Rainer, that as much as my guests were predominantly mental health professionals, not exclusively, my target audience was not specifically mental health professionals, although I could say to you, they could have learned a lot by listening to the podcasts. I think what's important is that you pitch it more generally, because what is the real intention? The real intention is not to be talking into a psychiatric bubble. You want to take it outside of that bubble. And therefore, when I said you have to really think about the content, you've got to be thinking about the access. And so what you would have seen in terms of how I was thinking about the podcast, I was looking at how psychiatry is relevant to society at large. And I was looking at society in terms of how happenings and events in society impact upon individual mental health, emotional well-being. So I was really pitching it very broadly in terms of the audience that I was aiming at. And I can guarantee you that the thousands of downloads for each episode were predominantly not psychiatrists or even mental health professionals. They were non-professionals. But this was a more informed audience who was interested, obviously, in psychiatry, interested in mental health, and they wanted more information. And they were obviously interested in the specific areas I was covering. So what you will see is this was not a lecture where you didactically speak about schizophrenia or major depression. I was looking at issues within conditions. So what is it like to live with somebody who has an eating disorder? Well, there are many sufferers of eating disorders, but think how many people are impacted by one person with an eating disorder, for example, and how much information they would want to have access to in terms of greater understanding. And so I was reaching to dominantly, I would say, a non-psychiatric population, not a specialist population. Having said that, many trainees came to me because, you know, the kind of issues we were dealing with actually are the kind of questions that used to get asked in our Part 2 college exam. These were questions that tested you as a psychiatrist in terms of how your psychiatric knowledge was being applied beyond the immediate. And so it really did require of you to have a much broader understanding of psychiatry as a biopsychosocial, and increasingly, because we started to bring spirituality into that biopsychosocial framework as well. So trainees would come to me and say, wow, we really enjoyed that, because for them, this was like a tutorial. And then there were families who would come to me and say, it was so helpful and informative. So what's really interesting to me is that without any specific grounding in doing this, I just went out and had conversations, but they were common sense conversations. They were down to earth conversations. Any technical terms, I would immediately explain for the audience and break it down. Nothing should be so complicated that you don't understand it. Everything has to be understandable. And I think on that basis, it becomes accessible. So, Rainer, I didn't set out to say, right, we're going to target this audience or target that audience. I put together the podcasts. I looked at what I thought would be interesting. I understood what I was trying to achieve. And I think that within each episode, the idea of psychiatry as a thoughtful, holistic discipline, which actually should be the template for all medical disciplines. We shouldn't be the only ones who have this approach. I think that came through very strongly. And I think it resonated with people because people began to appreciate a bit more about what psychiatry is. Because as I said, there are a lot of stereotypes about psychiatrists and who psychiatrists are and what psychiatry is all about. So I've gone maybe beyond the bounds of what you wanted to hear, but that's my answer.
I think Norman wants to ask something.
Yes, please.
Yeah, well, I was most impressed by what you've done. I mean, having done just a little of it, I know how tremendous amount of work you have done by bringing this out. Congratulations, you're still alive and look well.
Thank you. I must just add, Norman and myself know each other because Sartorius and Sabo are different versions of the same thing, Taylor.
Exactly. Yes, that's a translation of a name. Now, I wanted to ask you, do you have any, two questions, in fact. The first one is, do you have an idea how many people listened to this?
So
the second question is, whether you would be willing, interested that, in fact, the podcast which you have be included into the WPA website on the training material.
I would love that, Norman. With pleasure. You send me an email, I will make sure we send you the instructions how to move it across, and it's accessible on the WPA platform. It's been in my mind for a long time. I'll tell you what my reservation was. I didn't want people to think I was promoting myself egotistically. You know, to say, oh, it's Zabo's podcast. I didn't want to do that. So, you know what? I'm like a candidate for the papacy in the Vatican. You never ask for it; they have to come to you. But I think that's a brilliant suggestion. I would love to do that, and it speaks a little bit to what Rainer was saying in terms of who's the audience. But back to your first question, you know, Norman, you can never know how many listeners you have. What you can know is how many downloads you have. Right. You don't know how many people listen to that download or whether they in fact pass it on to somebody else. So all I can say to you is that we had between 2,000 and 3,000 downloads per episode, which, if you look at the where it puts us in terms of podcasts, we're kind of moving up into the top 10% of podcasts, and thinking that there's 4 million out there, that's not bad. But in terms of how many listeners, probably a lot more than that. And so I think that what's important is that you reach people who are receptive, and they then take the word beyond. And I think that, that I can't tell you, but I think there were many thousands of people who listened. And I was always quite surprised when people say, oh, I've listened to your podcast. I was like, wow, okay, great, you know, nice. And always I must say, very positive, and people got a lot out of it because it's accessible. It's scientific, and it's scientifically based, but it's made accessible, but it's not simplistic, not simple. And I think that conversations really flowed, but in order for the conversations to flow, you have to have a good structure. And so that is why it would take me so long to do my research, not just on the issue, but on the people I wanted to invite. I needed to know about them, who they were, and then I would structure. And so there would also be a logical flow, how I took you into the issue and how I walked you through it and how I took you out and what the take-home message was. And I always ended every episode with a quote from literature, poetry, wherever, something powerful that kind of encapsulated and spoke to the entire episode. So every episode, the quote at the end. I haven't got one from you yet, but maybe if we do more, I'll find one. But the truth of the matter is, that's how I used to end my episodes. And so that was also very important in terms of really thinking about something that kind of crystallizes what you've discussed for an hour. That's a take-home message for the audience. And so I would love for the WPA to take the entire 60 episodes and have them available as a resource. I think it's a fantastic idea.
All right.
So I await your email, and I will.
Okay.
We will make it happen. Any other questions, Rainer?
No, I think no. At the moment I'm fine. I think we should integrate our other members. You know how they, you know, to some extent, this is what we want to do here with this YouTube channel. We also have just trying to address it, but I find it sometimes difficult for myself to address it. I think I'm a person of not too many words. I'm not saying I'm completely shy, but I think I don't have the charm possibly you guys have. So I think sometimes it's trying to get into the right pitch, and I find it very difficult. And sometimes I find it much easier to, you know, you have to have less words when you're very academic. And you just can also hide between all the academic stuff. And I find it's making a story out of things that's very difficult. I think this is why you very often, when you go and meet doctors, that they just very much tell stories of individual people. So I think that's what and this is what people want to hear. So, but I think I have to learn from you and possibly listen to some of your
listen to the podcast. And just to say, we did occasionally have patients on the podcast too. So occasionally patients would come on. Obviously, we would anonymize them, but they were very comfortable. I mean, the episode we had on ketamine, we had a patient, and then there was an episode on trauma and functional neurological disorder, and we had a patient on. And so it was really interesting to get their insights. So what you see is that we had a very broad range of people, and yet it was scientific, yet it was accessible. Don't ask me how we accomplished that. It was just, you see, I think what it comes down to is it's just a conversation. Literally, you and me talking about it. And if you and I just have a conversation, believe me, you will have many words. You will have many words. You will chat about whatever it is that we're talking about that is of particular interest. And it was important to shift from that mindset where it's a Q&A. And that, if you listen to the very first episode, it's more of a Q&A because I'm still finding my feet, and I've had that traumatic experience of the disastrous first recording, moving straight into an in-person interview. It's a bit more Q&A, and I'm learning the ropes. But by season 4, completely different. I'm chatting.
So what's the future? What's going to be your future?
Well, the first future agenda is to get onto the WPA website. I'm very excited about that. So Norman, you've just given me a huge lift. I think I've got another 15 to 20 topics that I've kind of mapped out. Now it's a question of meeting again with the funder, the platform, and looking to see how we freshen up the podcast, because you don't just want to stay the same every single time. So we're going to have a meeting, I believe, sometime in December. There's been a little bit of a lag now, but I have to be honest with you. I think I was a bit burned out. 60 episodes in just over 18 months, and literally every weekend you're busy working on the podcast. You're sitting and you're working on the podcast, and it consumes you. And everything is about the podcast. You hear a conversation or you read an item in the newspaper, you're saying, yes, that's an interesting topic. Yes, I've got to bring that in. Could you be surprised how much mental health is out there in the media? So how much people are already sensitized to the issue? And I think in the wake of COVID, it was all about mental health. Fine. Now we've got a product that really speaks about that, but not in a reductionistic way, in a very issues-driven way, which I think is what makes it more interesting. And it's got to be interesting for you as the podcaster. I think it's very much about you, the podcaster, in terms of what interests you and how you engage with people and have conversations with people. So the future is maybe there'll be a season 5, possible, and probably sometime in the new year. We first got to meet to have that. But I think that it's got legs still, and it's got potential. So as long as there's a funder, as long as there's a team, as long as I'm interested, then I think it'll probably happen.
What's the funding for? And how much?
The funding, well, everything costs. What do you think it costs to go into a studio? What do you think time costs for engineers, for producers? It costs money. So part of your pitch is the funding. Time. My time costs money. Everything costs money. Everything is itemized, everything is funded, and then you work it out from there. So there is a cost factor, yes.
I think
For you, the listener, it's free.
Okay, that's fine. It's a bit like YouTube, anyway.
Yes.
Okay, so I think I don't know. It's my understanding Sujit is having to dash off, or it's the middle of the night at your place now.
Yes, I think we're done.
And I think we are going to have the next speaker. I'm not sure. I think it's Hans Grabe coming up. Is this correct?
This is correct. Hello.
Right. Okay. Right, Hans. Can you just? I don't know. So, are you in today?
I'm in today, and I would like to share my presentation.
Okay. First, I say very, very much. Lots of thanks to Christopher, thanks to Norman, thanks to Roy, and thanks to Daria. Very much so. And I think some have dashed off now, but I think applause doesn't work here at the moment,
No.
but I just do it mentally, and we have quite a few people, and the whole lot goes live sometimes soon, and or we just will present something. The other thing is now, I think for the next few talks, I would say the audience should shake off their shyness, and this is a one in a lifetime opportunity to ask very important people who are very knowledgeable. And as I don't see initially, I thought, all right, I don't know whether Rohit Valvaikar wanted to introduce the next few speakers, but before he does that, okay, before he does that, I finish. So Hans Grabe is a friend of mine. He worked in Bonn. We worked together, and he's very good into whatever long-term studies. And anxiety was an issue sometimes. OCD he was very focused on, and he's a great friend. And like many of my younger colleagues, he outperformed me completely. And he has a chair in the north of the country, Greifswald, which is on the coast in Germany. And please now, Rohit, if you can take over the chair. As I said before, Hans and to others, we decolonize the system here now, because we want to be a global association and a global audience. And so for that reason, I think it's not a one-man show anymore. And I would like to give Rohit the chance to lead the next few sessions. Rohit.
Hello, August audience. Today I'll be taking over the evening session, and I'm Dr. Rohit from India. I'm an early psychiatrist.
Can you just show your face, please?
Sure.
And Hans, in the meantime, if you can just try to share your slides, if that's possible.
In fact, just sorry for interrupting you. I'm sharing my slides right now. At least I can see them. Share.
All right. Okay. I think the problem is that Christopher Sabo, you're still on the screen.
Okay. Maybe I stop again and then.
Okay. Yeah, I think you can.
All right. Should I go ahead?
No, I've stopped sharing.
Oh, let's try again. So better now?
That's much better. Okay.
Okay, great.
Hello, August audience. Let me take this opportunity to introduce myself and the audience and the speakers therein. I'm Dr. Rohit, and I'll be taking over the session from Dr. Sujita now. To introduce Dr. Hans Grabe, as Professor said, he is a well-accomplished psychiatrist and a researcher. Dr. Hans Grabe will be addressing the intricate facets of the long-term consequences of traumatization, drawing from cutting-edge research in psychology and related fields. The presentation is poised to explore how traumatic experiences can imprint lasting effects on mental health, behavior, and overall well-being. By delving into recent findings, Dr. Hans Grabe will be navigating the nuances of resilience, coping mechanisms, and potential avenues for intervention in the aftermath of trauma. It promises to be an enlightening discourse, unveiling insights that contribute to a collective understanding of the enduring impact, traumatization, and the human side. Dr. Hans Grabe, over to you.
Hello?
Yeah, Dr. Hans Grabe, over to you.
So,
Hello.
can you hear me, Rohit?
Yes, I can hear you, Professor.
Okay. So you're finished with the introduction?
Yes, I did.
Okay, then I'm starting. Rohit, thanks a lot for the introduction. Thanks to Rainer for inviting me and to being so modest all the time concerning your own achievements, which are really great. In fact, I'm very happy to give the talk on the long-term consequences of traumatization, new findings. It's the third time in this round that I give the presentation on this topic, and I think I will share some already known slides with you, expecting that in the audience new members have been joining compared to last year. But I will also demonstrate a couple of new findings which are really intriguing and pretty new. So, yeah.
Can I just sorry, Hans. Can I ask you, did you take your language as German or English? Because when I see the captations, they sometimes make no sense. Now it works here, but make sure that if you take their language, that it's English. Yeah.
You mean the language for the PowerPoint or for what?
For the captations, so your captations don't make sense because you possibly have your captations so your language is possibly put to German.
Okay.
I do not know. You have to do it on your own. On your own.
Okay, that's.
I don't know, Daria. Do you know how that works?
Do I have to do it in the PowerPoint presentation?
I think Daria, can you unmute? Daria, please. Daria Ahmed, can you just unmute and just help us?
There's no problem from my side. I can see the screen and
no, but you possibly know he has. So it seems that the captations Hans has are trying to send it to German. So because I can see this Z, I can see some letters I would only see in German. So where is the language? I don't know.
This is the problem for all. Is there's nothing show from my side. I think you are opening your caption. There's a 3 dot above, and you can hide the caption because you are the main host.
Right. Okay. Can you? Okay, just let's go on then. If we can't, I just try to. Okay.
So yeah, because it's a quite conventional presentation. So yeah, this is the main building of our university in the city of Greifswald. It's a very old university, and in fact, it was established by the Swedish people that were conquering the northern part of Germany in the 16th century, which is quite interesting. And I will present a couple of data that we derived from our study of falls in Pomerania study, the ship study that has been conducted in the northeastern part of Germany. Yeah, you can see Berlin. So maybe I will switch this down. So, oh, now it's indicating that the screen share has been interrupted. Is this true?
You're visible.
I'm visible. Okay, then I'm just continuing. Okay, you can see Mecklenburg-Vorpommern, the northern part of Germany, and here are the cities of Greifswald and Stralsund next to the island of Rügen, which is really very nice. Okay, here are the white chalk cliffs of Rügen. This is our scanner from the study of falls in Pomerania. Since 15 years, we are investigating the whole body MRI scans from all participants of the study of falls in Pomerania. And this is just an example of a conventional GWAS plot, indicating that we are doing a lot of omics data analyses, which is quite interesting. But today I'm not talking about all the omics and genetic stuff. Yeah, We are following a multi-level systems approach, especially when we are talking about childhood trauma. Childhood trauma, of course, occurs in childhood. This is pretty clear. And this is also one of the main problems, that childhood trauma occurs very, very early in life, and that childhood trauma hits during a very sensitive period into the child's brain, because the child is developing, the child's brain is developing, all the neurons are being connected, and all the networks are doing all their learning driven by interactions and by the environment, by all the sensory input. And during this very, very sensible and vulnerable period, childhood trauma really disrupts and interferes with all these learning processes and all this stuff like memory consolidation and robust attachment and binding. So this is pretty harmful to many of the victims, and we are investigating in the adults, of course, a lot of genetic data, transcriptomic data, proteomic data, and we're doing MRI scanning. And in the end,
can I ask you, do you move the slides forward? Because I still see the study of health in Pomerania. Is this correct?
Oh, yes. No. I'm moving the slides forward. So, okay, maybe I will stop again, and I will try to share the presentation one more time. So now it should work again.
Yeah, if you go into presentation, yeah. Okay.
So, can you see my presentation now?
I can see Max Ernst, so...
Yeah, exactly. That's cool.
Okay, if you can...
I was talking about this slide, the childhood trauma slide, and all the different omics layers, the MRI, and the way that we try to connect all these different layers of information to make sense in a risk model approach to understand what is driving the onset and the maintenance of mental disorders. We all know that childhood maltreatment is pretty frequent. This is a study from The Lancet a couple of years ago. And already in this study, they came to the point to say that in the high income countries, 4 to 16% of all the children are physically abused, and 1 in 10 is neglected or psychologically abused, and that 5 to 10% of the girls and up to 5% of the boys are exposed to penetrative sexual abuse. And these are figures that run throughout each country and throughout rural areas, urban areas. These are, I would not like to say these are constant drivers of human society, but everywhere you make research, you find those numbers. Also in our beautiful landscape, in a pretty rural area at the Baltic seaside, where we are doing the research, also in this area, we find pretty robust rates of childhood abuse. We know that childhood trauma is associated with a number of mental disorders. In the clinic, we see all day long patients suffering from all these various kinds of disorders who have been exposed to neglect, to emotional, physical, or sexual abuse. These are high rates, and it's without doubt that childhood trauma is a driving risk factor for all these disorders. That's pretty clear. But I would like to back up those clinical impressions by data that we are collecting and data that we are allowed to analyze. I would like to draw your attention to the German national cohort, to the NARCO study. The NARCO study is a very, very nice study. It has been started in 2014. There are a lot of study centers throughout Germany. It's supposed to collect a pretty representative sample of the German population in almost each federal state. And in the first wave, in the baseline wave, more than 200,000 people were enrolled in the study. And during the follow-up wave, which is running right now, 117,000 subjects have been enrolled until the end of September. Probably there will be a couple of additional enrollments. And yeah, it's a huge study. And the assessment protocol is really huge with different levels of assessment. We have a broad level, level 1, that everybody is receiving, who's participating, and then we have level 2. Level 2 is even a more intense way of phenotyping the subjects. About 40,000 subjects are participating into the level 2 examinations, which comprise a very broad neurocognitive test battery, also a whole body MRI protocol, and various other tests and interviews. So the 40,000 sample is really deeply phenotyped, and the rest is, I would say, still very robustly phenotyped. You can do a lot of research with the whole 200,000 subject sample. Last year, I was already able to present our first paper from the NARCO that was published in the World Journal of Biological Psychiatry. Back in that days, we had only the sample, the starting sample available after a quality control, roughly 76,000 subjects. And we were analyzing in this paper the so-called CTS items, the childhood trauma screener items. The childhood trauma screener has been derived from the childhood trauma questionnaire. The childhood trauma questionnaire has about 28 items, which is far too long for such an epidemiological study, because time is money, and the participants are requested to fill in numerous questionnaires, and each single item counts in terms of participation, in terms of missing values and stuff like this. So we tried to reduce the 28 item questionnaire to 5 items that are representative of these 5 dimensions of physical neglect, emotional neglect, physical abuse, emotional abuse, and sexual abuse. And on the right side, you can see the prevalence in this sample of maltreated subjects. What's the definition of maltreatment? We say if you suffer, for example, from physical neglect to a very high degree. And the question was, for example, when I was growing up, I knew there was someone to take care of me and to protect me. And when the participants are indicating never or rarely, this is a severe rating score for this item, whereas sometimes, often, or very often, is the positive rating. So everything was fine in their childhood in terms of physical neglect. So just when they are indicating never or rarely, we consider them to be physically neglected. And this goes through the other questions as well. Emotional neglect, for example, someone in my family helped me feel important or special. Physical abuse, I got hit so hard that I had to see a doctor or to go to the hospital, which is really a very high level. Emotional abuse, people in my family called me stupid, lazy, or ugly. Sexual abuse, someone tried to touch me in a sexual way or made me touch him. So these are the items, the wording of the items. You can see for sexual abuse, the definition is a little bit broader. So when the participants are indicating this occurred rarely, we already consider this as being positive for this item. Whereas, for example, emotional abuse, you at least need the rating of sometimes, the scoring of sometimes, before we say this subdimension is considered to be fulfilled. So here are the prevalences. You see they are not too high because of our strict definition, but this is something that I would consider to be the core of maltreatment. And sometimes the subjects fulfill a couple of these dimensions. It's not only a single dimension, but they are interrelated, of course. And last year, I already showed that indicated in black, the people with childhood abuse experienced higher scores of depression in terms of PHQ-9 ratings. This is abuse, this is neglect, this is any kind of treatment. And GAD-7, this is general anxiety scores. Even there you can see it's a clear effect of childhood trauma, maltreatment, and also in the PHQ stress scale, you can see that those people who indicated childhood trauma many decades before still are suffering in mean from much higher values in terms of recent stress experiences. So, and now I would like to move to another paper from the NACO. This paper has been accepted for publication in the German Ärzteblatt, Deutsche Ärzteblatt. Currently it's in press. The title is Childhood Maltreatment as Risk Factor for Somatic and Psychiatric Disorders. I'm now interested to move this. During adulthood in a narco health study. Here we can see that roughly 156,000 subjects are enrolled in all these different disorders. So we were investigating in this study cancer, myocardial infarction, stroke, diabetes, COPD, anxiety, and depression. I just mentioned here the German wording because in the following figures, I'm sticking to the German word because I was not able to change the figure because it just had the PDF. So it's cancer is Krebs, and stroke is Schlaganfall, and anxiety is Angst. Probably you know it from the German Angst, which became internationally very famous. German Angst. So, okay, what did we do? You can see here on the y-axis the odds ratio for the likelihood of the occurrence of all these disorders. The first one is cancer, the second is myocardial infarction and stroke, diabetes, so COPD, anxiety, and depression. And in gray, you can see that these are the subjects who have indicated that they have no childhood traumatization or just a mild form, which we consider as none, or they are indicating a moderate to severe childhood abuse, which is indicated in the orange-red dot. So I will go through the different points. In cancer, you can see a statistically significant increase in the incidence of cancer in the people who are indicating a childhood trauma event. Myocardial infarction, you see there is a connection of the confidence intervals, but nevertheless there is some kind of increase in the rate of myocardial infarction over all age groups. Stroke, the third one, is very clearly elevated in the subjects with childhood trauma. Diabetes, it's also elevated. In COPD, it's even more elevated. And as we all can imagine, that the association to the mental disorder dimensions like anxiety and depression is even much more higher, with odds ratios between 2 and 2.5. So the rates are doubling in the general population. And I think it's important to mention that many people who are suffering or who have been suffering from childhood trauma in their childhood or youth, they are able to cope with it. But when the people becomes really under pressure or come under pressure, and if really life burden is kicking in, then their resilience to other stressful life events can be diminished. And this is an interaction with a lot of stress factors that can eventually lead to not only a mental disease but also to physical disease. But here in this figure, you just see the straight association of all subjects with childhood trauma without any other risk factors. So it's just the base rate of association. I think the next slide is pretty interesting. So it's the same like this, but we were stratifying the age ranges. And now the picture becomes more interesting. I will walk you through this slide. We are starting with cancer on the left side here. Again, all the subjects without childhood trauma are being set to 1 as its reference group. And in orange or red, you can see the subjects with childhood trauma. And now you have the different age groups. In circle, this is the age group under 40. With a triangle, this is a group between 40 and 60. And the last one is the group above 60. And now a very interesting picture emerges, because you can see that the younger age groups have a much higher odds ratio for the given physical and mental diseases when they have been exposed to childhood trauma. And now the associations become, let's say, more relevant, even more clinically relevant, because an odds ratio of 1.5 is a 50% increase in risk. So it's much more prominent. If I compare this to the previous slide, you can see the cancer risk. Yeah, it was, I don't know, 1.2 probably, or 1.15. So not that compelling, but if you really look at the age stratification, you see that the younger people have a clearly elevated risk for cancer when they've been exposed to childhood trauma. Also, the same story holds for myocardial infarction, 50% increase. In the age group now between 40 and 60, there were literally no cases with myocardial infarction below 40. Also for stroke, you see the increase. Also here, no cases below the age of 40. Diabetes, the same story. COPD, you see the elevated scores. There it's not that clear, but again, the youngest group is leading. And when it comes to the mental syndromes, anxiety and depression, you can see that the youngest groups have far more the highest odds ratios for the given disorder when they have been exposed to childhood trauma. So one conclusion from this slide would be that childhood trauma is really affecting the onset of the disorder, of the physical or the mental disorder. There's a shift to earlier ages of onset, which, to be honest, which we can't prove in this analysis because we simply stratified the age groups of the subjects. We were not stratifying the age of onsets because these data were not available so far. But it's pretty clear that with stratifying the age groups of the subjects, we also stratify to some extent the age of onset groups. So I think this is pretty interesting, and this becomes really clinically relevant because we see in everyday clinical practice that severely affected people from childhood trauma, they do suffer from multiple physical disorders. And here you can see that they do occur not only in numbers throughout the life, but also earlier in life. Okay, and now I jump back to the study of Pomerania. Our study at Greifswald University. Here we were conducting interviews, clinical interviews, for the assessment of depressive disorders. And you can see the lifetime prevalence rates were, of course, increased in subjects that have been exposed to childhood neglect and especially to abuse. The interesting point here is that we can see that emotional abuse is really the driving force behind a lifetime major depressive disorders. It's an odds ratio of 4, so a massive odds ratio compared to physical abuse, sexual abuse, or emotional neglect, which is still an odds ratio of 2, but the other one is 4. So emotional abuse is really a high risk factor for depressive disorders. This slide I have been presenting last year already, but I think it's an important slide because everyone can conceive the association between childhood trauma and depressive disorders. A lot of interactional stuff is going on, a lot of negative emotional binding, a lot of self-consciousness, and all the storyline goes along, which is clinically really reasonable and conceivable. But also in psychosis, it has become pretty clear that a lot of factors in childhood and adolescent are contributing to the risk of psychosis. And yeah, this nice figure really shows the more or less common concepts that we have first wave hits in the pathogenesis of psychosis, and we have second wave hits. So the first wave hits are very, very early risk factors that are occurring even before birth or around birth. You can have obstetric complications, you can have prenatal infections, you can have a couple of traumatic events in your childhood, and later on you get a second wave hit that is really destabilizing your vulnerable neural networks. And if all these factors are acting together in probably genetically predisposed subjects, you will experience something like the first episode. And you can see here all the risk factors that have been identified, like the childhood trauma here, and low childhood or adolescence functioning, tobacco use, male gender, single status, unemployment, affective comorbidities, physical inactivity, social deficits, ethnic minorities, and all the neurobiological risk factors that we know nowadays. So also here, the life environment plays a decisive role in the onset of psychosis. Yeah, this is a slide that I like very much because childhood trauma really kicks off a whole range of problems. First of all, mental problems that we've already seen. Then we have physical problems in terms of activation or dysregulation of the HPA axis, often associated with chronic inflammation and metabolic problems. And then we have behavioral risk factors, that we already heard about: smoking, drug use, alcohol use, physical activity, more or less inactivity, malnutrition, and all this adds up to the risk for cardiovascular disease or for diabetes. So this is a whole bunch of interacting risk factors, and there's a lot of data for this highly pathogenic environment and all these pathogenic interactions that are taking place in our patients. Yeah, so back and forth, highly interactive. So, yeah, and just to mention the association between childhood trauma and some of the autoimmune diseases like rheumatoid arthritis. It's interesting because we have to acknowledge that childhood trauma obviously leads to some very early dysregulation of the immune system. So the distinction between self tissue and tissue from bacteria from outside the body is not working properly. So there is a higher risk for autoimmune disease in subjects with childhood trauma. And you can say the increase of odds ratio for all these facets of childhood trauma in a patient with rheumatoid arthritis. Pretty robust odds ratios. And the same occurs when we are talking about multiple sclerosis. Just have to switch this one. You see case control study here, again, for emotional abuse and for sexual abuse and emotional neglect. You see pretty strong effect sizes, which are highly significant. So also in a brain-related disease, autoimmune disease, you have a higher risk in subjects that were exposed or have been exposed to childhood trauma. And this study, the AC study, it's a very, very famous study. I love to show the slide for everybody who's new into the field. Should really go to PubMed and visit the AC study. Many publications have been written based on this database from a health insurance company from California. Also dealing, you can see, with autoimmune disease, with ischemic heart disease, with pulmonary disease, and liver disease. It's really very interesting. And this is a paper that we were publishing 2 years ago. It's a paper that is really focusing on lung function. The good point about this paper is that we, of course, used questionnaires, but we also used objective measures of lung function. And you can see that we had 350 subjects with childhood maltreatment positive and more than 1,000 without childhood trauma. And these are the results from the questionnaires or from the interview. What you can see is that the patients with childhood trauma had a significantly higher intake of medication for lung function. They were reporting much higher rates of wheeze without having a cold, which is highly significant. They also were suffering to a higher extent from asthma and chronic bronchitis, but that was not statistically significant. And asthma attacks were much more prevalent. You can see an odds ratio of 4, which is quite nice. So the subjective experience was much worse in the people of childhood maltreatment. And when we used our objective measures of lung function, the picture changed. Let me just briefly describe what we did. we were measuring the FEV1. So the FEV1, this is the first expiratory volume that you can expire in 1 second. So it's a lab testing. The FVC, this is the forced vital capacity. So how large is your volume that you can really breathe in and breathe out if you work hard on this breathing operation. And you can see that all tests are non-significant. There are some slight differences, but they were not statistically significant in this sample, which is not really a small sample. So these are only minor differences. And compared to the results of the previous slides, one has to conclude that probably the patient with childhood trauma, they were receiving more medication. Maybe they had a very, very good treatment, and their objective parameters were not really different from those without childhood trauma, which can be really a very, very good result of all the medical treatment that is taking place in Germany. But in the end, it remains that, we're just going back, that the subjective ratings were much worse. So the Riese without having cold, the rate of asthma, bronchitis, the asthma attacks, everything was rated much worse by the participants. Disrespect the objective measures. So, and I think this is a point that maybe subjects with child trauma are more sensitive to physical stress, that they are more prone to negative subjective experiences, and that they are in fact suffering more from the same disease, from the same underlying disease, because of their vulnerability. Okay, this is a result slide from the ACE study comparing the degree of childhood trauma to the rate of cardiovascular disease in the ACE study. You can see here, this is the ACE score. With increasing scores, you have much higher ratings of childhood trauma. And the endpoint was ischemic heart disease. And this is a logistic regression analysis. And you can see that with increasing ACE scores, you have an increase in odds ratio for ischemic heart disease, which is increasing from 1.1 with one childhood trauma symptom in the ACE score up to 3.6 when you are at maximum with your childhood trauma rating. And when the authors were using different models, the odds ratio decreased a little bit. The different models are referring to different sets of covariates of different sets of confounders. So when we take a look at the fourth model, this is a model where they were really adjusting for everything, and they were adjusting for age, sex, race, education, and then they were adding smoking, physical inactivity, body mass index, diabetes, hypertension, and then they were adding anger and depressed affect. They were including all those covariates into the last model. And I assume that some of those confounders were in fact mediators. But okay, let's take it like it is. There was still a 2.3 odds ratio, so a 130% increase in ischemic heart disease, irrespective of all those confounders, which is a strong result and which really matches very nicely into the other data that are already presented. There are strong interactive risk factors, and childhood trauma also because it is occurring that early in life, is a driving force behind a lot of physiological and behavioral risk factors. Okay, we just have a couple of minutes to go. I will briefly refer to some of our results in terms of the MRI research and brain structure. I pointed out before that the developing brain is pretty vulnerable because, of course, in the prenatal phase and in the childhood phase, in the adolescence, the brain growth is performing really high tasks. The brain is connecting all the neurons, the networks, and is really making up a picture of the world, and everything is developing, the personality, the language skills, the social skills, everything. And stress might be very, very harmful to this process. And there's a study where the authors try to figure out in which phase stress is most harmful, and yeah, they define also stress on the HPA axis, where you get problems with the growth of hippocampus and the neuroplasticity of the hippocampus, which is really affected in the postnatal stress phase, or in adolescence, you have problems with the maturation of the frontal cortex. And yes, in adulthood, you have problems with the emotion regulation and the amygdala. And very early on, you get problems with neurodegeneration or with dysfunctions because all your networks are being exposed to too much stress. So it's something that is phase dependent, but in the end, you can say stress is not really good, at least if the stress level exceeds a certain threshold. Okay, this is a very, very well-known study, which has been replicated many, many times. You can see that there's a strong, clear correlation between the exposure to childhood trauma and the gray matter volume of the hippocampus. You see that it's, of course, it's a negative association. The more childhood trauma the subjects have been experienced, the smaller their gray matter volume is in the hippocampal area. We made a study based on CHIP with 1,500 subjects. And I think this is a very, at first sight, it's a very, very simple figure. Yes, it is, but it's interesting. It's really interesting because we were analyzing the interaction between abuse and no abuse with the severity of depressive disorders. Because, like I mentioned before, many people from the general population who have been exposed to childhood trauma learn to cope pretty well with the trauma, or have a lot of stabilizing environmental factors like grandparents or good peer groups and stuff like this. So they are able to outweigh the stressful childhood experiences. And they are performing pretty well throughout their lives. They have developed psychosocial coping strategies and probably also neural coping strategies. And the people who are developing depression later in life, they have probably not been able to compensate for the childhood trauma because they are developing a major depressive disorder. They are really suffering and they are not performing that well. And so we analyzed the interaction because this makes a lot of sense. So we take a look at the subjects with no depression. And if you look at the subjects with no depression, and here we have the whole brain cortical thickness. It's an overall measurement of cortical thickness, of brain integrity, you see that the people with childhood trauma, with abuse, have a higher mean cortical thickness compared to the non-depressed, non-abused subjects. So this is interesting because this could probably indicate that there was something going on, like compensatory mechanisms, really in neurobiological strengthening of the brain to really be able to cope with the childhood trauma. Okay, this is an interpretation, but probably it works. And we were also analyzing all these effects in various brain areas separately, of course. And if you go to the group of mild depression, there both groups are pretty overlapping. And when we enter the stage of severe, oh, is it possible to mute Imran? Imran, can you mute your mic? Okay, now it's silent. Imran, is it possible for you, or can I mute your mic?
I can do that. I think I should do that.
Okay.
Give me a second.
Great. So, and when we enter into the group of severe, moderate to severe depression, then we see something that we're expecting, that the people with childhood abuse and moderate to severe depressive disorders had the lowest cortical thickness in mean compared to the subjects with no abuse. So this is pretty straight line here. So the message is that the people with abuse are not performing bad or worse in every condition, but when depression enters so-called the game of childhood abuse, when childhood abuse is that severe that coping is not sufficient to keep depression away, then we see a neurobiological correlate in terms of lower cortical thickness. In the other end of the spectrum, people with childhood abuse without depression obviously are performing pretty well in their life nowadays, and probably they have developed coping mechanisms, psychosocial coping mechanisms that have a correlate in cortical thickness. So this, of course, is a lot of interpretation, but behind the data set, like I mentioned, 1,500 subjects, not too bad. And the confidence intervals are acceptable. They're not overlapping. Okay. So, and you can see here the brain areas indicated in red that are really affected from this interaction. So it's not throughout the brain, but these areas are really driving the mean cortical effect that I've been showing in the figure before. Of course, they are important brain areas for emotional and affective regulation. So, and now I come to my last slide. I will just show data from the SHIP study where we were comparing 4 groups of subjects. These are subjects with childhood trauma, with low resilience or with high resilience, distinct subjects, or subjects without childhood trauma with low resilience or high resilience. You see that, of course, there are more subjects without childhood trauma. This is clear if you compare the overall numbers. And for resilience, we made median split of resilience. The score, we just took the score and separate for males and females and made the median split. So you can see that it's kind of weighted here. And I will just go on. So this is the rate of lifetime depressive disorder in the given group. So the group without childhood trauma and with high resilience had the, of course, lowest rate of lifetime major depression, but still 11%. So let's go further. This is the opposite spectrum. This is the group with childhood trauma, moderate to severe, and with low resilience measured by RS25, the resilience scale. So the depression rate, lifetime depression rate, is peaking up to 30%. And the next one, childhood trauma, positive. But high resilience, you see that they are doing quite well. This is what I just mentioned in the study before, in the brain imaging study. There are people with childhood trauma who are coping pretty well. And the rate 13.8 compared to 11.2, that's not a too big difference. So they are really performing both very, very well. And now the last group, childhood without trauma and low resilience. So you can imagine the depression rate is probably lower than 30%, but it's not that low. It's 18.4%. So the take-home message, there's strong protection by resilience, and this also makes the point that it's probably important to, if you're really interested in understanding the long-term consequences of childhood trauma, it's probably important to separate these groups, to separate the group that is really suffering also from nowadays low resilience and maybe high rates of depressive disorders, compared to the people with childhood trauma but with high resilience and low rates of depressive disorders. So there are two very, very different trajectories. I would bet that also in terms of all the physical diseases, we would have very, very different prevalence rates between both groups. But that's just an hypothesis, and we are trying to get more data on this, of course. So a summary: childhood abuse is prevalent, more than 10% in the general population. Childhood neglect is even more prevalent, more than 20%. There's a high impact of childhood maltreatment on the etiology of different mental disorders, as well as the physical health, especially in younger people, that we learned from the NARCO study. There might, especially in severely affected patients, there might be a strong alteration of psychosocial and psychobiological development. And the question is on the transgenerational trauma transmission, something that can probably take place in terms of the psychosocial behavior, the interaction, all the model learning from the parents. But there are also findings that point to altered microRNA signatures in people with childhood abuse. We have also published a couple of papers on altered microRNA patterns in whole blood in subjects from the general population that were suffering from childhood trauma. And it's conceivable that these signatures probably affect the second generation. And it's known that sperm are a carrier of a lot of microRNA information to the egg of the woman. So this could be a biological way to transport environmental information from one generation to the other via biological ways and molecules. So thanks a lot for your attention. I was very happy that I could be here with you today. So questions?
Just, when you look at these brain studies, what's cause and consequence? Because some people, let's say kids who have less education or whatever, have ADHD or autism or alcohol, they behave a little bit, if you have whatever less or ADHD or ASD, wouldn't that cause more trauma as a consequence? So what's cause and consequence? So if you have behavioral problems because you have brain, poor memory or brain disorders or anything, so what's the cause and consequence there? How can you sort this out? And the other one is if you take poverty, or let's say poverty and inequality away, how would that look like?
Yes, I'm totally agreeing with you that sometimes the victim is driving the abuse by himself or herself as well. We can't rule out this way of interaction. Yeah, the victim is not always the passive one, and especially when people have been victimized, they change their behavior and they become probably exposed to new forms of traumatization. They are engaging in fights. They are engaging in probably emotional abuse because they are misbehaving in school and kindergarten and stuff like this. So I really think that the assessment of childhood trauma is something like a surrogate parameter for a dysfunctional environment, a dysfunctional interactive world. And when we are talking about genetics, we know that at least in conventional families, the children are the product of their parents. And the parents are carrying 50% of the child's DNA, and vice versa. So it's a mixture, definitely of biological factors and behavioral factors, and especially, when we're talking about autism, I think there might be parents that are really very far away from autism, but they are being really traumatized by their autistic child because it's misbehaving in a very strong way. It has obsessive compulsive rituals. It's very, very sensitive to any kind of environmental change or behavioral change that's going on in the family. So it can be very, very stressful. On the other hand, when we are talking about ADHD, it's something where you can really feel that the whole family is affected. Often we see the parents, they come in our treatment, they get psychotherapy, and then they are reporting from their children, and they are reporting a lot of school problems, and they're reporting behavioral problems. And in the end, when they were children, our nowadays patients and the parents, they were the same. So there also might be a genetic component that is jumping from generation to generation, and we just measure something like the behavioral outbursts of all the genetic complications. Yeah.
Right. Okay. Are there any other questions at the moment?
I'll ask one question, quick question.
Yeah, sure.
So thanks for the presentation. I just wanted to clarify, and I looked at your last slide with the data. It seems to me that it's the resilience that really differentiates whether you've been sexually abused or not in terms of subsequent depression. If I looked at those percentages, I don't know if there's even a statistical difference. But it seems to me that the resilience more than the abuse seems to predict whether there's subsequent depression. Is that a simplistic reading of the situation, or is that reasonable?
When we take a look at exactly these data, your interpretation is right. But these were subjects from the general population. And if you go into clinical departments, you see a lot of victims who only have a very, very small degree of resilience left because their traumatization was very severe. So even if you have high scores on the childhood trauma questionnaires, it's general population, and you know, if you have reached the maximum of the scale, you still in real life can experience much more traumatization than the maximum score of the score. You know, there's no end to drama and to traumatization.
Right.
And in the clinical practice, we are seeing people who have been traumatized for years and with very, very different traitors and different methods and means. And so the scale is not really differentiating in this high-end area of abuse. Not really.
Okay, fair enough. Thank you.
Yeah.
Okay, I have to say thank you to Hans. Thanks a lot. Yeah, so I think it was a great, I don't know, just right. I'd like to say thank you. I don't know whether you disappeared now already. Just double checking.
Yeah.
No, you just all right. Okay. Yeah, I think I have to come to Germany. I was recently in Berlin, so I think I have to come to the north. And yeah, thanks a lot for this presentation. I think the data, I think the amount of work which goes into these data is so horrendous. I think, and then people come up with questions. Yeah, was it the resilience or something else, or is it the cause and the consequence? I think epidemiology is a quite unfair research area, isn't it? You know, it takes an awful lot of time, an awful lot of work, and we have to struggle quite a lot. But thanks a lot. Christopher, do you want to make a final comment?
No. I don't want to have the last word. I'm not that important. But I did want to say hello to Joao. I saw him sneaking a peek at all of us. There he is. I see him there. Old friend and collaborator. Lovely to see you. But Hans, thank you for your presentation. Rainer, thank you for hosting us. I think it's been a very successful afternoon stroke evening. We've had some very varied presentations and really good stuff. Kudos to you, Rainer, for bringing it together.
Right. Okay. So that's I think what we do as well. We, you know, eventually we will YouTube some of this, and it will then. Sadly, you know, people. It's quite a tense day today. So let's say it that way. Now I can introduce, or I think so. Jose has hello. Right. Okay. Can you hear us?
Hi.
Okay, if you can start. So thanks for coming up and being active.
I'm presenting. Yeah, let me just. I have
slides?
2 computers because I have some technical problems. Let me just share my screen with you.
Right. Okay. I think so we're old friends, and but as I said before, we decolonize and get the Europeans out of the way. I would like that Rohit would introduce you. Is that okay with you? Rohit.
Yeah, for sure.
Yeah, sure. I can take it up, Professor. Hello, Professor Joao, Mauricio, Castaldelli, Maia. Welcome to.
Can you also share the slides properly? I don't know. Yeah. Okay.
Yeah. Are you with my screen there? Is it okay? Are you?
We can see your screen, but you know, you have this outline stuff. If you take the next slide outline stuff away, then we possibly be better off.
Yeah. Let me just do something here. Okay, just one moment.
Maybe you can tap on the use slideshow. That will be taking care of it.
It's just okay.
Yeah,
that's better.
Yeah?
Perfect.
Better now?
Better.
Okay.
I start recording now. Okay, Rohit, you're
Sure. Hello.
Yeah.
Hello. I'm thrilled to introduce our next esteemed speaker, Dr. Joao Mauricio, a visionary in the realm of geopsychiatry. Dr. Joao is set to unravel the groundbreaking insights surrounding the Cape Vulnerability Index, an innovative approach that bridges the gap between geography and psychiatry. With pioneering research, he has delved into the very intricate interplay between environmental factors and mental health vulnerabilities. Join us in exploring how the Cape Vulnerability Index illuminates the dynamic relationship between the geographical elements and the susceptible to psychiatric challenges. This promises to be a very captivating journey into the intersection of geography and psychiatry, offering fresh perspectives that redefine our understanding of mental health in a geocontextual framework. Over to you, Professor.
Thank you very much for your kind introduction and for the opportunity to meet my dear friends Chris and also Heiner and all the other speakers. I was with Hans in this last presentation. But today we are talking about geopsychiatry, this is the outline of the presentation. I'm going to first introduce this field of that is, as he said, is a field of interaction between geography and psychiatry. Then I'm going to introduce this CAPE index, followed by the results of the CAPE Global report, the CAPE index applied to the whole world. And then I'm going to focus more on Latin America. This will take more the largest part of the lecture, talking more about Latin America. I am Brazilian, and of course that we are trying to use CAPE here. So, what is geopsychiatry? Geopsychiatry is a developing field which studies the interface between geography and psychiatry. The main focuses are on effects of climate change, disasters, globalization, population growth, movements, urban agglomerations, agricultural production, industrialization, geopolitics, socioeconomic transformation, and also cultural practices. And for this reason, it's a really intersectoral field that can involve professionals from different areas like geographers, physicians, anthropologists, sociologists, doctors, not only psychiatrists, psychologists, architects, urban planners, economists. So it's a really truly intersectoral field. And geopsychiatry is really in line with the biopsychosocial model. This model, which is it was developed by WHO, tried to explain health and illness and healthcare delivery through biological, psychological, and social aspects, and all the complex relationships among these dimensions. And so geopsychiatry, we believe that serves as an excellent example of this field. Other close and intersectional scientific areas of geopsychiatry involve like medical anthropology, social psychiatry, health economics, cultural psychology, social epidemiology, for example, social psychology. So it's medical geography as well. So we have a lot of other intersectoral areas that can dialogue with geopsychiatry. But geopsychiatry hot topics include examining the causal chain involving the geographic risk factors and incidental mental and substance use disorders. In addition, this field also searched for the protective factors, the environmental interventions that can have been also investigated and implemented. So the CAPE index is just is an index that was developed under this field of geopsychiatry. The name is the Compassion, Assertive Action, Pragmatism, and Evidence Vulnerability Index. It was an index, a global index that highlights the need for assistance in countries with a high degree of vulnerability. So the index is composed by 9 items that I'm going to go into more detail. And it offers some data for assessing vulnerability in each country. So these are the items. The items are life expectancy at birth. This data is extracted from the WHO database. Disability adjusted life years, which is a metric extracted from Global Burden of Disease study. The index of doctors per person, which is derived from World Bank database. Gross domestic product also, which is derived from the International Monetary Fund. The Gini coefficient, which is a statistical tool used to measure income inequality. We also have the current conflicts, which is also a metric used in the index. Number of refugees by country of origin. The corruption perceptions index, and the last is the external aid received. So I'm going to give more detail how we calculate CAPE, but these are the nine metrics that we use to compose the item. We know that each of these variables, positively or negatively, are associated with the prevalence and the incidence of mental disorders. And we can have and give examples of each one of the item and the association with the incidence and the prevalence of mental disorders. And so the idea was to compose a global index that can assess a global vulnerability. So the idea is to try to identify which are the countries that are in the most needs for external aid. And so this is the idea of the index. I'm starting showing you some global data, this CAPE global report. So we analyzed data from 193 countries in total, and including 47 from Africa, 35 from the Americas, 53 from Europe, 27 from Western Pacific, 11 from Southeast Asia, and 21 from Eastern Mediterranean. Of course, that we were not able to calculate this index for all the countries because many countries doesn't have some of the index that are the items that are used to compose the index. So after exclusion, we have only 137 countries, and we ranked the values for each CAPE item. So for each CAPE item, we have a ranking of the country with the most difficult in this item. So for example, the country with the lowest life expectancy at birth, or the country with the lower, for example, the highest corruption perception index. And then we ranked it and we selected the top 20, those who are in the top 20 to score on this item. And I think that not surprisingly, these are the most vulnerable countries. So we have 23 countries that scored, that were at least in 4 of the top 20 for of the 9 items. And so which are these countries? So we have 4 countries in Latin America. We have Honduras, Colombia, Haiti, and Guatemala. In Southeast Asia, we have Myanmar. And in West Asia, we have Iraq. 17 countries in sub-Saharan Africa, namely the Central African Republic, Mali, Ethiopia, Cameroon, Sudan, Guinea, Zambia, Mozambique, Lesotho, Nigeria, Rwanda, Niger, Burkina Faso, Chad, Benin, Azerbaijan, and also Côte d'Ivoire. And as we can see here, this table presents the prevalence of mental and substance use disorder among these 23 countries, with the most vulnerable countries. And the average prevalence of mental disorders was 12.45%. The highest prevalence was in Sudan and the lowest in Azerbaijan. And regarding substance use, we found an average of 1.7%. Highest value was found in Guatemala, 3.6, and the lowest 0.7 in Sudan. This other table presents the prevalence of mental and substance use disorders on the 23 opposite countries, those with the highest quality of life index, including the most wealthy countries that you know, so Australia, Austria, Canada, Czech Republic, Denmark, Estonia, Finland, Germany, Iceland, Japan, Netherlands, Norway, Oman, Portugal, Slovenia, Spain, Sweden, Switzerland, United Arab Emirates, UK, and United States. And there were no countries from Africa. The average prevalence of mental disorders was indeed higher than those at the highest vulnerability, was 15%. The highest prevalence was found in Australia with 19, and the lowest in Japan with 10.5%. And also for substance use disorders, we have a higher prevalence with 3.5 for substance use disorders, with the highest in the US with 6%, and the lowest in Oman with 0.8%. So it's a kind of surprising to see how the wealthier countries have more higher values of mental disorders, higher prevalence of mental disorder, and but we were surprised, but not so much, because we know that there are some reasons for this differences. I just want to add that these values come from the prevalence of mental disorders come from the global burden of disease study, and so obviously that there is a urgent need for evaluating mental health in the most vulnerable countries. It's very important to detect mental disorders in these countries. We obviously that we have a correlation among the 9 index and the incidence of mental health. So that there is, we believe that there is also lack of data, and also poor knowledge, a lower level of mental health literacy, both among health professionals and the general population. There is a lot of stigma that also occur, and especially in low and middle income countries, stigma attached to mental health. There is a lack of mental health services, and also data systems that are not well developed, and the taxes of the rates of psychiatrists, which is the differences are very high. So, for example, in New Zealand, we have 28 psychiatrists per 100,000 people, compared to 0.1 and 0.5 in Guatemala. In Sudan, 0.1. And so obviously that we with more psychiatrists, we have more higher levels of mental disorders. And as we see here, that these are the some kind of stratification of the prevalence of mental disorders by the level or income level, and you can see that the difference is very clear. So it's important, we believe, that to increase mental health literacy, we have some interventions that are indeed very, that are trying to approach this question, because in countries that we have 0.1 or 0.5 psychiatrists per 100,000 people, we must have other professionals involved in mental health, and even the less skilled professionals, health professionals. So we have the MH gap, which is a way of trying to address this by doing task sharing and task shifting, and so moving the mental health detection role to less skilled health professionals, and not only doctors, but also nurses and technicians. And this is very polemical, but is certainly a way of trying to think about how to help these people, who certainly that there is a huge gap of people that are not detected with mental health. And so we discussed a bit about the global situation, and obviously that me and other people from Geopsychiatry group, especially Julio Torales, who will be talking, I think, tomorrow here. And but me and Julio, we were when we looked at the Latin American data in the global report, we found that this data did not reflect exactly the situation in the region, because we had a lot of other countries that were in a very high vulnerability situation. And so we designed another study to just evaluate the CAPE index in Latin America. So in Latin America today, and I'm going to now on, I'm just going to talk about Latin America. We have 33 countries, and we have countries in North America, namely Mexico. We have countries in Caribbean, and we have countries in South America. We have also 15 dependent territories in the region, and in the region of 670 million people, with almost 22 million square kilometers. So who are in Latin America? Who are the people in Latin America? The people are people that shared in the history experience of slavery, indentured migrants, conquest and colonization by different countries like Spain, UK, Holland, Portuguese, and also France for centuries. And these were followed by movements of independence. These movements start from early in the 19th century and onwards. So we still have some territories that are dependent. So we have territories dependent from UK, the Netherlands, France, and also the United States more recently. And which are the countries, the most populous countries? There are some countries that concentrate the vast majority of the population in the region. We have Brazil with 213 million, followed by Mexico with 126, Colombia with 51, Argentina with 45, Peru with 33, and so on. These are the most populous countries. We also have Haiti in the end of this list, just after Honduras with 10 million people. This information is important because Haiti is a highly vulnerable country, and we are going to talk more about Haiti in the further slides. So the region, after several years of low growth, the economy is facing a new setback as the with COVID and post-COVID situation. We had some external shocks, like the 2008 crisis, which really impacted the region. We had lower demand for commodities from developed countries, which is also affecting during the COVID, which affected a lot the region. We had a lot of flight restrictions. With these were very, very heated. The main activity in many Caribbean countries. So it was a very, very difficult situation during COVID. There were also people that were facing some financial crisis before COVID, some countries. And there were also some the endemic situation of Zika virus in the region, very high levels of informality in work. And we also have a lot of people that live in Latin American Caribbean that rely on remittances from people that are living in other wealthier countries like the US, or it's the most common, but also in other countries, and that send money for their families that are still living in the region. This is really common, unfortunately. So in 2022, there was a restart of the economy, but some scars of the pandemic remain. There is a urgent need for a more dynamic, inclusive, and sustainable economic growth. The region also, in the geopsychiatric perspective, suffer a lot from natural disasters. It's not the only region that suffer, but there are some important topics and aspects here. We have around a quarter of the 8.0 plus earthquakes in the region. We have a lot of floods. Brazil is one of the top countries for floods in the world. we have 20 on average. We have 20 earthquakes, 7.0 plus since 2013. We had 17 hurricanes, and some Caribbean countries, for example, in the last year, lost 25 to 50% of the harvest because of the drought. So it's a region that suffers from natural disasters. And how are these people regarding health, regarding burden in terms of here we have the data from the Global Burden of Disease study, and we see that the difference between the global trend and Latin American trend is diminishing through the decades, and one of the reasons for that, coming to our field, is the increase of mental health importance. So mental health disorders are climbing up the ranking. If we look at the difference between 1990 and 2019, we have mental disorders in the 60th position here compared to the 90th position in 1990. And here we can have a good view of the mental health situation in terms of seeing the difference between the global rate of DALYs regarding mental health and the Latin American curve. So the distance increased, especially during the beginning of this century, and has been kept during the last decades. So DALYs, just for people who are not familiar, DALYs is a metric of burden, obviously that are not only for mental health, but for all type of diseases. And it includes the burden regarding earlier deaths, so years lost, and also the lower disability, so a higher disability, and the years living with disability. So is a very is a valid metric, and so here we are presenting the metric for mental disorders. So the idea was to explore the vulnerability in these countries in Latin America, to identify which are the countries that should be prioritized for aid. This was the first time that somebody used CAPE to try to really focus it on Latin America. So these are the 9 indexes that you already know. So we used the same framework, and here we have the results for our countries regarding the ranking, and I'm going to make your life easier, and I'm going to highlight for you which are the most countries. Obviously, that you were seeing Haiti here as the first in many of the items here, but I'm going to make your life easier and select the most important countries. So Haiti, as I said, it was it had the first position in the vulnerability index in Latin America. It was first in many of the items, and also second in the refugees and also corruption perception index. So how is Haiti? Haiti is a former French colony, and since the 30s was led by autocratic rulers. It was named as the poorest country in the West many times, and it suffered in 2010 with an earthquake of magnitude 7.0, and is a very populated country. has around 10 million people living there. And the main ethnic group is Black, which the vast majority. Official language are French and Creole. And main religion is the Christianity. And the life expectancy is really low. We have 62 for men and 68 for women. The second country with most in the ranking was Guatemala. Guatemala, together with IT, also appeared in the global report of CAPE. But Guatemala, as you see here, is present in the top 10 for almost all the items here of the CAPE. So how is Guatemala? Guatemala is a former Spanish colony. It was a region that was under the influence of the Maya civilization. And it has a very populated, around 17 million people living. The main ethnic group is the Mestizo, which is a mix of Amerindian and white, with an important Maya minority. And the languages are mostly Spanish, but also Maya. And the main religion is always Christianity, but the life expectancy is significantly higher than IT. The third country was Honduras. Honduras scored a period in 5 of the top, in the top 10 here in the Cape. So Honduras is a Spanish colony also, and in the last decade suffered a lot from natural disasters. It had important immigrant efflux, but it still have a large population with around 10 million people. And the main group is Mestizo, with also with important Black and Amerindian minority. Official language is Spanish, and main religion Christianity, and a higher life expectancy with 78 for women and 71 for men. Guyana also appeared here in 5 of the indexes. Guyana is a former British colony, is the only English-speaking country in South America, and it's still a member of the Commonwealth. It has a lower population. It's around 800,000 people. English is the main language, but we have also other idioms as well. A mix of religions, but of lower life expectancy, closer to IT. The 5th position, we have Suriname. Suriname appeared 5 times. And Suriname is a former Dutch colony with around 0.6 million people. A lot of descendants from African slaves, but also works from India and Java. Varied ethnic groups. The official language is Dutch, and there is a mix of religion with predominance of Christianity, but it has a higher life expectancy. It's good to see that we have, independently of the former colony origin, we can have a higher vulnerability situation. Other countries that appear in the ranking, we have Belize, we have Nicaragua, we have Venezuela, we have Bolivia, and also Dominican Republic. So what we do with that is not exaggeration to say that the world is facing a number of crises at the geopolitical level. We are living, especially these last years, from the current COVID-19 pandemic, along with the increase in population, to climate change, human-made and natural disasters, ongoing conflicts leading to mass migration, increase of refugees and asylum seekers. However, the impact on mental health is still kind of invisible. The mental health scars are not taken into account. Even with the spread of infectious diseases and really the infectious diseases are important, and we are not saying that they are not important, but most of the times we have a lot of focus on infectious diseases and less focus on other kind of problems, and namely mental health, for example, but not only. And so the idea is to start to give more attention to these questions. When we look at the external aid received in our ranking, this external aid received is a tax by population. We don't have the most, the countries that are in the higher needs receiving the higher amounts of aid, external aid. For example, Haiti is not here. We also don't have Honduras here. So it's important to pay attention to these most vulnerable countries. When you look at the percent of DALIs, we see that, for example, Haiti have a very low percent of DALIs compared to the other countries, and obviously that infectious diseases are occupying a lot of the percentage of the DALIs, but we cannot forget that mental health is there. Mental health disorders are there. And so when we look, and you can see here and say, oh, IT is not suffering from mental health, and this is not true indeed. Even with a very low developed mental health detection system, IT, when we look at the rates, we see that IT is more or less together with the other countries and is not the country in the lowest position. Honduras is in the lowest position here, but IT is suffering from mental health. We can imagine that if we have more and more approach, probably this will be even higher. So we can look here and see that Latin America has more or less the same position for mental disorders. This is the Global Burden of Disease study in the ranking for the percent of DALIs. But when we look at the most vulnerable countries like Haiti, Guatemala, Honduras, mental health is more in lower positions of the ranking. So the idea is not obviously that there are other important diseases occurring in these countries, but the idea is not to forget mental health. For example, here we see that in Haiti, comparing the trends from 1990 to 2019, we have an increase in the position of mental disorders, but is still in the 11th. So on a global level, we have human rights violations are perpetually experienced by individuals with mental health. In many middle and low income countries, they do not have access to the basic mental health care and treatment required. The only care available is on psychiatric old style institutions, which are most of the time inhuman, and there are people living in very degrading conditions. There is also certain cultures and religions that view mental illness as weaknesses, and those diagnosed with mental disorder are sometimes deemed as unproductive or unable to keep a family. And this kind of views are unfortunately more common in these countries. So there is a important question regarding stigma of mental health, which we should certainly approach. There are difficulties with seeking professionals help. So, and this is something that should be taken into account. Internalized and treatment stigma, and we know that this stigma is especially important in ethnic minorities, in youth, men, military people, and also among health professions. So you must be asking yourself, so, but okay, Joao, you were talking here for a long time and about vulnerability, but what should we do? What should governments do? So I believe that governments should seek scientific-based measures in order to adequate their own mental health services to the new and adapting situations, and as well as to the cultural background and structural stigma that exist in their societies, and to be able to order a more to offer a more feasible mental health care to their population. What should aid donors and ONGs do? We believe that it's important to recognize the most reliable groups acting in these most vulnerable countries. This is not an easy task, but it's important. And historically, as a result of Basel impact on in the region on politics, and Latin America has moved from an asylum-centric to a community-based care structure, and this is very desirable. So it's important that the mobilization of the society in favor of this community services and the activation of the asylums. Obviously that it's important to do it gradually, because otherwise people are just going to become disassisted. A good example of that is the psychosocial care centers in Brazil, the CAPs, in which we can have, these are community mental health services. And we have briefer hospitalizations up to 15 days. There is a possibility of people to stay during the day in the service if they need, or to pass the night, but just briefly. And this, we believe that is a very good example of how to move to this asylum-centric mental health system. The CAPs can help in this, in a psychiatric emergency overcrowding, which is something that was attested, for example, in Brazil. We have a lot of people that with the activation of when we have less asylum institutions, these people start to be more time in the psychiatric emergencies, and CAPs could be good community health, mental health services could be good services to receive these people and compare it to asylums. So it's a good way of dealing with this situation. These community health services and Basel impact also culminated with a decline in stigma, which is highly desirable. So Brazil is somewhat a good example in these terms. I think this is my last slide. What should we do as psychiatrists? We believe that psychiatrists should be mental health advocates, engage more with families and communities, try to stimulate this kind of community mental health services. Just we talked about CAPS. We believe that contemporary psychiatry is one of the parts of the social justice. So it's a right of the people to have a good mental health care. Psychiatrists should also offer the best care available, and do not be dismotivated, and try to do the best they can, even in lower resource settings, which is not so easy sometimes. But also try to educate their patients for helping them to advocate for their health, and do not be in a situation, in a position in which like doing nothing. So I really believe that psychiatrists should be more advocates in some kind of services, trying to engage more with people and families and communities. So this is my email. I hope you had a good time in this hour, and I'm open now to questions.
Right, give me a second. I think if before this question, I would ask you. So how is South? I think the problem is that South America is possibly more than one country, and it's more one thing, isn't it? So what you see there is possibly that you have a high variety of different. You call it a high variety of different organizations, and different countries. And I think the variety with all the history must be more than North America, or the variety is possibly much more than what we here expect in Europe or maybe Asia. I think you have these very, very, very poor country like Haiti, and where lots of wars. So what can we learn from a situation like this? So is there a country which is like a beacon where we should focus on? Or
Yeah. I thank you for the question, Rainer. And the situation here, we highlighted the as you say, the most vulnerable countries, but even in the large countries, like big countries like Brazil, Argentina, we have sub-regions that are very, very vulnerable. So the sub-regions, and this will be a next further step that we are going to take in this endeavor. But what we learned from here, we learned that there are countries in which there is a huge need for mental health initiatives, because it seems like mental health is a kind of invisible, and there is no health without mental health. So we are not asking people to not, for example, to stop initiatives to tackle the infected diseases or something like this. But there is a huge need for also to improve the mental health disorder detection in these countries. And yes, there is a large, very huge heterogeneity in the region. The needs are different. As you see in the most vulnerable countries, we have, for example, Haiti and Honduras with a very lower life expectancy. And we have some more also very vulnerable countries with a higher life expectancy, like Guatemala and Suriname. So there is a kind of heterogeneity, and each country should be obviously investigated for their needs. But as I showed in the very colored graph, mental health perhaps is not in these 5 most vulnerable countries: Haiti, Guatemala, Honduras, Suriname, and Guyana. Mental health disorders are not taking the importance that they must have, we believe.
Right, I think Rohit wanted.
I'd like to ask a
Yes.
question.
Yes, Professor. So I wanted to ask more so about, so I am a participant of WPA Early Career Psychiatrist section. It would be great pleasure for me to know more about how WPA Action Plan Group works on geopsychiatry with you, Professor, as a co-chair.
Oh, okay, thanks so much. So now
just show your face, Rohit. Just nobody can see you.
Sure. This is
okay. That's fine.
Hi.
Hello.
And so we move it to a special interest group now, and it's not the action plan group anymore. So now in this last in Vienna, we changed it to a special interest group. We have monthly meetings, and everyone here are very welcome to become a member of this special interest group. In this group, we are dividing our actions in 3 dimensions. The first dimension is research, that we are doing this kind of research, but also other more sophisticated research. We are conducting, for example, here in Brazil, we are starting to assess mental health of prevalence among the migrants, the Venezuelan migrants here in the country. There is another group that are measuring mental health disorders among people in Armenia, in internal migrants in Armenia. There is another dimension for education. So we are producing some education modules on geopsychiatry, trying to spread knowledge about special situations in terms of migrant psychiatry, in psychiatry in situations of conflicts, how to deal with migrants. And so this is another dimension. And the last one is an advocacy dimension, which is led by people who are working with large global associations, and even with WPA, to try to perform initiatives to include mental health care in different countries. So we have, for example, Emeritus Professor Albert Persotke, who is in discussion with the president of Guyana, trying to implement a good mental health system in Guyana. So these are the 3 dimensions, and everybody who are here are really welcome, not only psychiatrists, but also other mental health professionals too. So it's just to write to me and an email, and I will include you in the next meeting.
Great. Thank you. Thank you, Professor.
Yeah, okay. I say thank you. And I think I like your talks and the variety of talks. You know, last time we had such interesting stuff about smoking. I remember that. And a lot. You know, I think you are the one who is the man of all trades in psychiatry, I must admit, you know, so very impressive.
I don't know if you invite me for the next year. I don't know which will be the topic, Heiner. But
okay, that's a given deal.
You know that you can count on me. You and Chris can count on me every year if you need. Just if you need. But I know that there are other.
No, that's fine. I think, you know, it's really great to hear something completely new. And I must admit, you know, I think what I learned last year in smoking I learned now on South America. And I must admit, I think I was always confused about what's happening in South America, not with politics, but, when you think about psychiatry, because there's so much variety in this country, and you have Chile who have quite stable, Peru works quite stable, so you don't never know what's all about. And then you have Honduras, and you have these overseas territories which are quite confusing, and you don't know what they're doing. Are they just copying their how you call it, their owner countries, or I don't know? So are they copying their mental health, or
yeah.
So that should be some interesting scientific approach to look how whatever Dutch how a health system works in whatever in Guyana. I don't know how it there. No, it's
Suriname.
So that's
yeah.
I don't know what you want
sure.
to comment on that.
Yeah, I think that in these territories we still have the high income countries supporting their countries, and there are some countries that is really they really rely on this internal but external funds from the dependency on the high income country. But even in these countries, when we look at Suriname, it's interesting to see. You see that mental health detection is not really high there. Mental health is it's a very different ranking compared to Holland, for example. So people in Suriname are suffering a lot, probably from mental health without the proper care. This is also the situation in Guyana. Guyana has a lot of internal aid and from Commonwealth interventions, but they behave more like a low-income country in terms of mental health. So what we have is, I repeat that, but mental health seems to be invisible in this country. So there is a lot of support for infective diseases care, and especially maternal mortality, to decrease maternal mortality. But mental health is still a really taboo in this country. So it's something that we need to develop a lot. We also have a very important problem. People in these countries, the physicians, they are people are they go to the high income country to study medicine, but most of them do not come back. So sometimes the physicians go to France or to Holland or to UK to do the specialization, but they don't come back to the country to act as a psychiatrist or any other specialty. So this is another problem that we have to deal with.
Okay, I have to say thank you and welcome Christian Schütz. Christian Schütz is co-editor of the Global Psychiatry Archives. He is a good old friend, and we met on skiing holidays in I don't know, was it Austria, where we just heard our first talks, and he later became a colleague in Bonn, and nearly I would have been a colleague with him in Vancouver, but I didn't dare the jump to Canada, and visit him, and I was quite impressed. So, but Rohit is going to give a more formal introduction, and I wish we keep in contact, and I'd love to hear your talk. I must admit something similar to Joao, who like you just jump. They don't jump just continents. They also jump nearly whatever, the whole of psychiatry in one go. So last time it was about, or this time it's psychedelics, and last time it was legalization about drugs. So I really admire you, and and you're very busy, and we're grateful you're coming here. But Rohit, you wanted to say something?
Yes, I very much look forward to hearing from Professor Christian Schwartz. As a psychiatry postgraduate, and through my special interest in substance abuse and addictions, I am very much interested to know as to how the psychedelic treatment and how rather new horizons in the treatment with respect to cyclic assisted psychotherapy is something that could drive future horizons ahead. Ladies and gentlemen, let's welcome Professor Christian Schwartz, who will be talking about on a very intellectual journey with his illustrious career marked by groundbreaking contributions. He's here to illuminate us on the intersection of psilocybin-assisted treatment and how we have the particular future horizons further on the same topic. He's from UBC and Vancouver, Canada, as Professor Rainer introduced him rightly. We look forward to hearing from you, Professor.
Thank you very much. Can you see my slides? So, what holds it all together is that I'm an addiction psychiatrist focusing generally on addiction and concurrent disorder. But I do obviously have an interest in the new and developing areas. I will talk about psychedelic medicine as we are starting to run studies here on psychedelic medicine. We'll talk about the background and the neuropharmacology, the current status of the treatment, which is fairly new, and then end up with discussion and summary. First, the substances. The substance which probably all of you know is LSD, which was developed by Dr. Albert Hofmann in Basel in, I think, in the 1930s. All the psychedelic substances have been Schedule 1 so far, and that happened about 50 to 60 years ago and stopped the psychedelic research at that time point. And obviously, currently, we are experiencing a renaissance of this. I will talk about the different substances a little bit, mainly with a focus on the question regarding therapy. And LSD is quite bioavailable, quite fast. When you look at the duration, it says 8 to 12 hours. Generally, it's intoxicating, or the psychedelic effect lasts for 8 hours, which is clearly a long time. Let me see it. Okay. The substance which currently is the substance which gets most of the attention is psilocybin, or magic mushroom is the plant where psilocybin is mainly kind of like produced from. Again, Schedule 1, the time of the psychedelic experience or the intoxication is somewhat shorter. It's about more like 6 hours. It says here 4 to 12 hours, but with this more standardized substance, it's about 6 hours lasting. So similar to LSD, a little bit shorter. And then the last substance I want to mention is the DMT, which currently is not researched very much, but I mention it simply because it is currently being discussed, and the duration of action is way shorter than the duration of action for LSD and psilocybin. As I mentioned, there was a lot of research on LSD in the 1970s or until the 1970s. And with the Scheduling 1, it became much more difficult or impossible to do any research. And there has been ongoing research, but only in the last 10 to 20 years have we seen a surge again of psychedelic research. What you can see here also is that there is some LSD research, but when I'm not talking about MDMA, by the way, which is also mentioned here, which has a little bit of different mechanism, which sometimes is put into the same pot also with ketamine. We'll talk about that maybe a little bit later, but I will focus on psilocybin and LSD. And what you can see is really the main number of studies is on psilocybin. And the simple factor is the duration, because when you do treatment with these substances, you need to have a psychotherapist with them for the duration of the intoxication time. And what it means is, sorry, with LSD, you need 10 a psychotherapist or a nurse for 10 hours supervising the patient or working with the patient. And FDA and Health Canada, the agencies which are responsible for getting the substances marketing or making it possible to use it as medication, have mandated actually for 2 therapists to be present during the sessions. That has been the case because there have been in the initial phase of the study incidents where the therapist did inappropriately cross professional boundaries, and the patient during that time are very vulnerable. So currently the mandate is that you have to have 2 nurses or counselors with the patient throughout the time of the intoxication. This is again the hours. What you can see, DTMT is much shorter. There is currently studies going on with DMT, for example, in the Netherlands, Wim van der Brink. There is also another way of shortening the length of the current psychedelic experience. It is not clear, and it's probably not necessary to have like the long-term psychedelic experience to have the clinical effect. And so shortening it would be helpful. The second way of shortening this would be through using an antagonist, and that is a study which came out this year, where Matthias Lichty, who was one of the biggest researchers in this area, reversed the acute response to LSD using ketanserin, which is an antagonist on the serotonin 2A receptor. When we look at the psychedelic effect, that is the effect which seems to be necessarily to have the treatment outcome. The subjective experience can be measured in the altered state of conscious rating scale, which was developed in Switzerland. And what you can see here is actually, if you look at psilocybin has the strongest effect on complex imagery and elementary imagery, so it's hallucinations. When you look at ketamine, it has, so to say, the peak in disembodiment, a more physical experience. Again, ketamine is also much shorter in its action. And with MDMA, it's more the spiritual experience, the blissful state. So while there is overlap in the experience, there is some differences in the different psychedelic experience. Ketamine obviously has been improved, and it was ketamine's success in treating depression which initiated the whole psychedelic renaissance. This is the full assessment of the altered state of consciousness, which is a fairly long questionnaire and is currently being reinvestigated because simply trying to make it a little bit more shorter. One question which has come up is, when we do psychedelic treatment, is it the subjective effects or is it some other effects? And are these subjective effects actually only epiphenomenon? So do people really need to have the subjective effects? And currently it seems to be the case that it is necessary to have the subjective effects to be effective. There is also this approach where people do microdosing, meaning they give small doses over long effects where there is no kind of immediate subjective experience similar to the psychedelic effects. And the data indicate that this approach might not be as effective. If anything, there is a high correlation with expectancy, which actually indicates that it might be placebo effect. So what is happening? I mean, this is a very disruptive approach. It's very different from the medication in psychiatry, which you take over long times, often lifelong, that you have an interventions which is, if anything, closer to ECT, where you just do have 1 session or 2 sessions and seem to have an impact which is long-lasting. The length of the effect has not been studied at the moment, but it's definitely clear that it has effects lasting for a half a year to a year. And the explanation why this is the case is currently not really clear. The hypotheses are that there's increased cognitive and psychological flexibility. So there's a, so to say, shake up and the new openness towards changing. There is an increase in psychological insight, and there's a heightened emotional acceptance. So why is this happening? There is pharmacological explanations, but there are also psychological explanations, and both are actually, if anything, happening in parallel. I talked a little bit about the psychological effects, but we can look at the brain too. And what we have is generally when people look at the brain, there are 2 levels. One is the more molecular level, which is the pharmacological level, so to say. And the second is more the network and circuit level, which is more the level characterized by neuroimaging. Let me first look at the molecular level. All psychedelics increase the serotonergic 2A receptor stimulation, and I will talk a little bit about that. It increases indirectly the cortical glutamatergic transmission, and that means it increases neuroplasticity, which is actually something which is also discussed with ECT. Then finally, there's a very separate effect, which is decreased inflammation. So psilocybin has been studied in humans a lot, but also in animals. And this is animal studies showing that psilocybin does increase the spine density after the administration of psilocybin. It ameliorates stress-related behavioral deficits, so it has a positive impact on learned helplessness, and it has an impact on the neurotransmission. The person who has done most studies on the mechanism of psilocybin is Xaver Vollenweider from Switzerland. He has been studying it for 30 years. He mainly has not looked at the treatment outcome, but has more looked at the mechanism. And he came up with this picture showing that psilocybin is metabolized to psilocin, and that there's agreement, increases the activity at the serotonin 2A receptors, but has also impact on other receptors. LSD has additional impact on dopaminergic receptors. And these serotonergic activation has indirect activation to GABA, dopamine, and what is probably very important is the glutamine release. He kind of come up with a quite comprehensive picture of how this is all related. I will skip that. But since we are as psychiatrists quite aware of the serotonergic mechanism underlying the treatment with SSRIs, the question is, so if that is that approach is impacting on the serotonergic system, what's the difference? The SSRIs are actually more active on the 1A receptor, which is more in the limbic system. So the explanation given here by the English group, which has done a lot of work on psilocybin, is that you have a reduction by the SSRI on the limbic responsivity. So you have a reduction in the stress experience, and this indirectly increases resilience, and they enhance the emotions, while the 2A receptors are more located in the cortex, and psychedelics increase the serotonergic 2A receptor signaling. The cortical entropy is increased, which really means increasing chaos, which is then kind of like translated into reduction of the rigid thinking. That's at least the hypothesis. And so to say, this reduction in the rigid thinking increases the capacity to reassess environmental experiences, and reassess also the personal experience, the emotional experience. So it is kind of like, again, the idea that there is increased flexibility and increased possibilities for modulation and change. And this is also kind of the idea that when you have psychedelic medication, you combine it with psychotherapy, because you can utilize this increasing flexibility to change the outlook and to change the interaction with the environment, but also with personal experience. In imaging studies, there has been data produced showing that the brain seems to decrease modularity. That means an increase in the functional connectivity and an increase in the overall entropy. So what it does mean is there is an increased connectivity in the sensory cortex, but there is a decreased connectivity in the association cortex. So overall, there's a little bit of changes in the different modules of the brain. What Madsen was writing is the serotonin 2A receptors critically mediates effects on neural processes that manifest reduced functional connectivity within discrete brain networks. So it's reduced integrity and reduced segregation. So there is a more talk between, not within, specific regions of the brain. There has been demonstration that the receptor activation is associated or is running in parallel with the psychological experience, such as self-dissolution. And that also been shown that the changes in the connectivity are related to the outcome. So we have the changes in the brain being related to the experience per se, but also being related to the outcome. Speaking again for the need to have this psychedelic experience to have the positive outcome. Kallivayali again summarizes that there are decreased integrative processes and increased sensory processes. So there is the capacity for change is increased. Currently, the big issue with the studies is that we have very little solid evidence. We have a lot of studies which have not really large group sizes. Here I have been focusing on substance use disorders. There has been studies on alcohol use disorders, and what you can see is that the sample sizes are fairly small. For most studies, 10 persons here, 15 persons 95 subjects is one of the largest studies, if not the largest study so far. Then when you look at major depressive disorder, this is the largest is with 56, are still fairly small studies. So currently the results of the studies are very impressive and very convincing. But one issue has been that most of the studies are really at the level of phase 2 studies, meaning studies which indicate safety of the application and indicate a possible positive outcome, but no definitive studies, really. These are kind of like ongoing studies at the moment. And when you can see the sample size go up a little bit, we are part of these alcohol studies, which is being conducted in Canada and in Finland. And the sample sizes go up a little bit, but overall still kind of like limited studies. We see also, which I did not discuss before in the slide, more RCTs, less open label studies, but there's also some issues with RCTs. Let me see. Oh. Okay, the issue with RCTs is that really it's very hard to have placebo-controlled, because you need to have the psychedelic experience, and the patients do know if they are on the active medication or on the placebo. And I will talk about that a little bit more. When you see also one other aspect on the follow-ups, the follow-ups are often fairly short, 12 weeks, 8 weeks. So there's still a lot to do in that area to get the data we need to talk about a established study. Some clinical aspects of psychedelic approach. Currently, it's a highly selected population which is being tested. We, I think, have so far around 5 patients, and we have screened 200. There is a highly good preparation set and setting, obviously, is important. So the patients need to be well prepared for the psychedelic experience. The setting is, that is the setting. It looks even a little bit nicer by now, but that is when we started. This is the setup, the room. Then I already discussed of the issue of professionalism, that the participants, the patients, are very vulnerable during the psychedelic state, and that is a concern, specifically when these approaches become more standard. It currently is very costly. We have to have a physician for 4 hours and 2 professionals for 8 hours for each session, which is considered quite high cost. And while we so far have not been experiencing or seeing a lot of side effects, we have to say that we are also treating a very selected population. This is again the comparison of the different studies. This is a non-hallucinogenic study, and when you can see included in the studies, in the recent published studies, is like 5% or 3%. So it's a highly screened population. The main issue screened for is history of psychosis. So we exclude, for example, anybody who has a relative, close relative with psychosis, a history of any form of psychosis, a history of any forms of suicidality. I already talked also that it's very difficult to develop a placebo. People have tried other substances, but the problem is that you know if you're experience a psilocybin intoxication.
Christian,
When
you show your, I can't, Christian, just to stop. Can you make sure that we can see your screen and the video? So I don't know this. It's black now with me.
It's black. Okay.
Yeah. All right, that's better.
Can you see it again?
Yeah, I think it seems, you lost a little bit of that's darker now.
Can you see it now?
No, it's darker now. You had it lighter in a bit.
Better?
Yeah, it's better, getting better. So I think possibly your screen is going a bit low. Yeah, that's fine.
Okay, sorry about that. So I don't know if it's that slide because I just added that slide this morning. You can see that I saw movements and things that weren't actually movement, which is reported in nearly everybody who is on psilocybin and practically nobody in red on placebo. And the one report which sticks out for placebos, I felt entirely normal. So this slide clearly shows that it's practically impossible to do a placebo-controlled trial. We are trying, and we are seeing now if we give some psilocybin that the expectancy is higher, but this is one of the issues still in the field. Others have tried with benzodiazepines, but people know that this is not the same if they're a little bit sedated or if they have a psychedelic experience. One thing to try
I have to moan again. Sorry, that's better now.
Okay. So, I don't know. I don't see any change on my side, so that makes it hard for me to adapt. Sorry. Let me know if there's a problem again.
Okay.
So one thing is we are running an expectancy assessment with the study so that we can see if there's a correlation between expectancy and outcome, which would be an indicator that we have a placebo effect. The big issue is also that obviously with psilocybin study, we will have a lot of people who have high expectancy on that, so that within the study field, we have to see if the effect sizes we are seeing currently will be maintained once we deal with, so to say, a population which is less well selected. There is also some approach now trying to understand if certain personality traits have an impact on the outcome, but this is just being started. When we look at overall, and I'm summarizing the results, psychedelic treatment is associated with enormous expectations. That's one of the issues I'm seeing at the moment, is that the participant in the studies often have come with high expectations, and we have the problem of blinding. So there is still this issue in the field that some of the effects might be really kind of like placebo effects. We have been seeing first promising studies. However, if you look at the overall situation, there is a lot of pilot studies and a lot of short studies. So there's the need for larger and more comprehensive studies. Interestingly enough, this approach is very transdiagnostic. So we are seeing this approach being conducted in very different fields of psychiatry, from OCD over major depressive disorder. I'm focusing on substance use disorder. So we are currently running a study on alcohol use disorder, but we are starting a study on opiate disorder, and we will next year start a study on stimulant use disorder. The psychedelic appears to have very few side effects. The main issue being that we see a small increase in the blood pressure. There have been reports on some people developing anxiety during the session. But overall, I think on average, when medication is available to support people, for example, with anxiety, like benzodiazepines, that has been used in less than 1% of the participants. There is also a big discussion about the psychotherapy going with the psychedelic approach, the integration psychotherapy, which tries to help people to understand the experience and translate it into the therapeutic outcome. And there is some standards being developed currently, but there obviously is not any consistency yet. Then if it is developed and if it is effective, it would be another, I would say, disruptive treatment, not very dissimilar to, for example, also TMS and ECT, changing the capacity to intervene acute or punctual without the patient needing to continue to take a medication over long term. I already indicated that one of the interesting aspects of these TMS and psychedelic is that it's very transdiagnostic, and it seems to have impact on more than one disorder. This is specifically important for somebody like me working in the field of concurrent disorder, where we are always looking for interventions which are kind of like reaching maybe a broader or more basic process, so that we can have impact not only on one of the mental disorders, but maybe on more aspects of the mental disorders, which might be the course for concurrent or dual disorders. And that's it. Thank you very much. Sorry.
Right, Christian, thanks a lot. Thanks so much. Can I ask you, sorry, just to be visible here. Can I ask you, I tried my initial PhD thesis, I tried to do with Hans Leuner, who was psychobilin, and but the whole idea they had was doing some psychotherapy or psychoanalysis. So what are you guys doing then during the time when people are whatever, elated, psychotic, or
yes, that obviously when people are in the state, one of the main thing is to keep them from kind of like dealing with it, right? So that is, it's really kind of like the preparation phase where you kind of like discuss the experience, and then afterwards to try to integrate it. So we do kind of like have a focus on change, and we do actually combine this approach with very traditional motivational interviewing, which is important for substance use disorder, and some CBT approaches. So the idea is, again, to increase the openness and increase the capacity to discuss, have more insight, but also to have more kind of like a flexibility in capacity to change. So in the studies we're doing currently, we have we have 8 sessions, 8 psychotherapy sessions. We are conducting 2 before and then 6 after. So it is quite limited, actually. I know that other groups, like in Switzerland, like Zurino and others, they have way more psychotherapeutic interventions. But given these are research studies, and also given the North American context, the psychotherapy is actually pretty targeted.
All right. But you know, how, so would the psychotherapy be at the same time when you give the psychedelic treatment?
No. The counselors and the psychotherapists are with the patient during the time of the and they discuss with them during the time of the psychedelic experience, but the main work is really done before and afterwards.
All right, okay. So and you wouldn't, you know, so the idea of this Hans-Georg Leuner was more or less to do it at the same time.
The thing is that probably the level of psychedelic experience is important, right? They have substantial psychedelic experience, so it's not just a little bit a change. They sometimes really start kind of like yelling, rolling around. So it varies, the psychedelic experience, but it is not really kind of like during these specific phases that the psychotherapy is applied. It is there, for example, there is a discussion afterwards, what was the experience, and where can you go with that? It is a lot about opening up and a lot about, so to say, having new possibilities and moving on. But that's not happening. It can happen during the session, but it's not like the session is supposed to be the main focus for that.
Right. Is there any other questions? I don't think so. I think some people are a bit knackered because they had now 7 hours of.
I know.
But so I think we just generated a little bit of a psychedelic experience, having whatever lectures going from just from around the world. So I think I don't know, you've possibly seen the program. So I think we have seen quite a lot. And I would say thank you to you. Thanks for making it in your busy schedule. And I hope we meet soon. And I think I close the session today. And thanks a lot. Have a good time. And the other thing is we have to take into account that some of the Asian colleagues, they're slightly already past midnight now. So, this is a disadvantage of a global thing. So the only disadvantage we have people from more of all the continents, and except Australia. I'm quite anxious about what we do when Australians join, because then at this point in time, it might be utterly difficult because they start another hour. And the same thing, we don't have Chinese people at the moment, so they're more Eastern, so possibly their day is nearly over before we start. Anyway, Daria, did you want to say anything? Right, okay. Nothing to say. Okay, so Christian, just I don't know what's the time for you, so you can go out for whatever.
It's noon. Generally, if I do these global things, it's way worse. I mean, I'm part of 2 global kind of like groups, and one always want me to participate at 4 o'clock in the morning, which is not the optimal time to do it, and the other one 6 o'clock in the morning, which is fine. And so I was very happy about.
So we try usually starting in the East. So the people in the East give the first lectures, and then to the West we get the last lectures. Anyway, so what's your time now in
Vancouver?
Vancouver.
It's 11:45 at noon. So that's perfect.
Fine. Okay, that's when we started at 1 o'clock, and now it's 8 o'clock. Anyway, so have a great time. Thanks so much, and I think we should meet sooner or later.
Okay, thank you very much. Thanks.
Again, come to Scotland and let me know. Okay, bye-bye, and I say goodbye to everybody. I don't know. Okay. I think it's going down now. I think interestingly enough, we had some people who have been, I think 4 people came from last year, so I don't know. I think Amalina Zulkifli and a guy from Switzerland came again. So I think we get our little group of fans, So see you then. Okay, bye-bye. I finish now. Okay, bye.